It looks right, but that doesn't mean it is right. All right, good morning. I'll just call the meeting to order. And it's a pleasure to be here, and Happy New Year. And for those of you that I haven't met, it's just a delight to be able to get to connect with you. And I'm looking forward to this first meeting. There was some chatter at the door of what was sort of the decorum, if you will, coming in here. I was like, your guess is as good as mine. This is the first rodeo for me, but I'm excited to be here. I want to cover a couple logistics before we get started in terms of public meeting sort of logistics in that regard. First, just want to let folks know that we have transitioned to the public meeting via Teams, and our opening slide has a little bit of information about how attendees can turn on closed captioning subtitles for those with accessibility needs. In the process, as we've transitioned to Teams, and Dina and I were discussing this morning, obviously is a little bit different in the Zoom platforms that we have used in the past, but the details that you need should be on that particular slide as we move forward. Also, just a matter of note that public meeting attendees will only be able to activate your audio and or video during the designated public comment period, which is outlined and part of our agenda. And for board members here who have joined us in person, thank you so much for doing that. Remember to turn on your microphones so that we can pick up the appropriate amount of audio sound for those that are joining us virtually. So with that, I'm going to do a roll call to identify members of the board who are with us, whether their presence is in person or online. So, and I'll apologize if I make any mistakes or corrections related to names. I'll only do it once, and you can hold me accountable in the future if I do it wrong again. How about Laura Christofferson?
Good morning.
Great. Pamela Cruz.
It's Pam. Good morning.
Hi, Pam. Allison Polson.
Good morning.
Good morning. Carrie Schaefer.
Good morning.
Omid Hadera.
Don't think we have him quite yet.
Okay. We are expecting him, I think, in person. Oh, there's Omid. Perfect. Omid Hadera. Perfect. I just want to make for the record, right? Terry House.
I don't think Terry has joined us online yet.
Okay. Donna Hanson Murray.
Good morning.
Morning, Donna. Thanks for joining us. And then we also have to my left, Katie Hatfield from the Attorney General's office. Great. And as I said at the top, my name is Ryan Moran. I'm the director of the Healthcare Authority and board chair for this year. I'll just take a matter of moment. This is the first time, as I mentioned, that I have been with the board, and very excited to kick off the board process and the board retreat today. I joined the Healthcare Authority in August, and just a little bit about me. I joined the Healthcare Authority from just a very small move, 3,000 miles east from the state of Maryland, where I was serving as the state's Deputy Secretary of Healthcare Financing and the state's Medicaid Director for Maryland. And prior to that was in roles and responsibilities leading community health center systems, as well as hospital operations administration in the Baltimore and DC area. So I'm really excited to be a new Washingtonian. I, in partnership with Dave, am also excited to take a more intentional role and responsibility of the director of the Healthcare Authority, chairing both the PEB and the SEB boards as we move into this new calendar year. I feel that's an important responsibility. But in addition to sort of the wonkiness that I have and interest in healthcare policy, of the value of bringing together the purchasing power that the agency has with both Medicaid and PEB and SEB and our other programs and focus areas of interest, this particular subject of PEB and SEB is a matter of personal pursuit for me. I am surrounded by a family of educators and those that work in school systems. My mom actually is still the school secretary of my local elementary school in rural Coal Country, West Virginia, a town of about 84 folks, 83 I like to joke since I left. And she still assumes that responsibility. My uncle and aunt who lived next to us raised us and were very active in our state's school union. And that was just really a privilege to be able to understand those implications and the importance and the important role that benefits play in the role of supporting our educators across the state there in West Virginia. And now this feels like a full circle moment in terms of all those particular experiences and things that surround me to be able to be here and to be able to step into this role as not only the director of HCA, but also to be able to chair both the PEB and SEB boards in the spirit of public service. So I am particularly excited about that, and I thank you for your warm reception and your greeting. I look forward to getting to know all of you a little bit better as we move forward in the process and throughout board meetings. Also, I just want to take a moment and uplift and thank our division of ERB, the PEB and SEB team, for the employees of the Healthcare Authority. I have just been extremely impressed, obviously, by the level of professionalism, organization, and attention and due diligence to detail, not just in terms of the meeting structure and organization. I felt like I did little preparing for this conversation today because of the level of preparing that our staff do, but also the day in and day out under Dave's leadership of working to make sure that we are in best service to the people that we serve, both through our PEB and SEB program. So thank you, ERB team, for all that you do day in and out. I see it, and I am so appreciative of your work. All right, so a couple of other things before we get started on today's agenda. I'll just note that for board members who are here virtually and in person, we're going to go through, we have a long day today, obviously, but it will be helpful if you can hold some of your questions until each of the presenters are finished with their presentation, or when the presenter makes an intentional pause and asks if there are questions. Same for board members who are attending online. You can use, if you have a question once that pause has occurred or at the end of the presentation, there is the hand function that you can raise on the Teams function to ask that you have a question, and we will be ensured that you are called on. Also, in preparation for this, I understand that there are no specific resolutions that the board will be taking at today's retreat. And we will invite the public, as I mentioned earlier, to provide some comments at the end of our meeting during the designated portion of the public comment period, which I think is to begin at 1:55 p.m. on our agenda. And at that time, we will also call on members of the public to raise their hand in the virtual environment to be recognized by our staff, and we will ensure that they're participating both from their audio and visual, and Dina will make sure that we're all set up in that regard as well. All right, I think with that, I'm going to pass it to Dave to provide an overview of today's agenda and to really kick us off on the content of today's retreat.
Good morning, Chair Moran and members of the board. Dave Eisbinger here for the record. I just want to welcome you back. It hardly seems possible that 6 months has passed by. In some ways, it's extraordinarily fast. In other ways, it feels like we were just together. So time really does fly for the programs and the state and just life in general. Before I cover the agenda, I do want to share an update with you about the board. You might be looking around the room and counting and going, there's only 8 of us, but there are 9 positions on the board. And that's because Myra Johnson is retired and she decided not to seek reappointment to the board. So working with stakeholders to look for successor nominations to the governor's office so that she can join Pam in service of representing certificated staff in the schools from the school districts. I just want to highlight Myra served on the SEB board for 3 years from 2023 through the 2023 through the 2025 board seasons, but she also has the unique distinction of having been the only person to serve on both the PEB and SEB boards. She served as the non-voting K-12 PEB member for 5 years from 2015 until that position was retired when this board and was created and the board program launched. It used to be that the PEB board had some non-voting positions that would be triggered to voting status if enough school districts employees were voluntarily joining the PEB program. That never happened, but she served diligently for 5 years in giving advice and insights. And then when she was contacted to say, hey, would you like to join the SEB board and be able to vote this time, she jumped at that opportunity. So I just want to publicly thank Myra for her tenure on both boards and wish her well. I do want to highlight, so today, the board retreat, I always think of it as we're going to do a journey through time. We're going to do the past, present, and future. We're going to step back into the fall, talk about how open enrollment went. We're going to talk about the present, which is the legislative process, and then the future, which are the things to come this board season. So in that vein, we will start off the retreat. We usually have some sort of educational panel discussion. And so we have a discussion about kind of healthcare access and cost impacts that are related to policy impacts either at the federal or state level. Then again, we'll start with open enrollment, the legislative process, where we are with the budget. We'll talk about the benefits planning cycle. The retreat is often the time whenever we have a brainstorming conversation with the board about things that you'd like us to be thinking about analyzing for future benefit changes. Preview, it's going to be a bit different this year. See budget. More on that as we get there a little bit later today. John will also talk, then we will go into benefits 24/7. So we had a lot of technical updates in the past year, 2 years to both boards, and our new CIO will be joining Gene Bowie to talk about where we are on benefits 24/7 right now and for the future. And then I have an update on the fully insured procurement process, which was a hallmark of conversations as the board finished up its 2025 season. I'll then preview the rest of the year and we will be done for the day. A couple of housekeeping reminders. If you are here in person, you need the restroom, walk down the hall. If you see elevators, look to your left. And if we have an emergency, we will walk purposefully across the street to the parking lot that is the visitor lot. That is honed over the years. It's purposefully. I used to say I would run, and I was like, no, we're going to walk purposely. We're not going to be panicked whenever we exit in an emergency, if that ever happens. And then last but not least, if the public has questions about presentations, just a reminder, you are free to look at the last slide in the board materials that were published earlier this week, and the presenter's contact information is there, and you can send questions in real time so that they are at least captured real time, and then staff can follow up with you after the board meeting. So just a quick reminder there. And with that, I will turn it back over to you, Chair Moran, to kick us off.
Thank you, Dave. Appreciate that. So yes, I think we're going to start off today's conversation with the panel discussion, as Dave mentioned, regarding some of the impacts of healthcare access and costs in the current healthcare environment. And I think our discussion today is going to be facilitated by John, our benefit strategy and design section manager. So I'll invite John up to be here. There's also some information on the panel members that have been invited to be part of that discussion that are within your packet. I want to note that that is on tab 3, so you can learn a little bit more about them. But with that, I will ask John to introduce our panelists and we will begin the discussion.
Thank you, Chair Moran, members of the board. As was kind of foretold, we have a really good group this year that has been able to join us. We're happy to have them. Very different perspectives and very knowledgeable about what we want to be talking about today, and providing an overview of some of the changes that are happening, as Dave said, at the state and federal level, and some of the maybe less obvious impacts those types of changes might have on our programs or commercial health insurance. So to introduce our group, on the end, we have Dr. Ty Jones from Regents Blue Shield, his medical director. We have Dr. David Ward. Thank you. I had Edward in my mind, but it's my apologies. David Ward, who is a practicing family practice physician and senior medical director at Kaiser Permanente. We have Dr. Jeffrey Ankeny, who's also a senior medical director at Kaiser Permanente. And then we have, very fortunate to have join us this year, Mr. Ian Corbridge, who is from the Department of Health and is the director of the Office of Community Health Systems and Quality Assurance for the Community Health Systems. So again, very different perspectives. We'll kind of launch in here in just a moment, but I think it'll be a good conversation for everybody. So again, panelists, thank you for joining. I want to start by just kind of acknowledging there's been a lot of discussion and a great deal of media coverage nationally about some of the changes that are going on and being recommended at the federal level and things that are happening in our own state, sometimes in reaction to those, sometimes in planning for those things, and sometimes proactively before those things even happen. And that's kind of what we want to delve into today. But one of the items at the federal level, there are a myriad of topics that are being discussed, one being healthcare affordability and access, another being pharmaceutical affordability, and there are a number of different ideas being broached there, including direct consumer approaches from the federal government and pricing negotiations. We've talked about that with the board a number of times over the last year and a half, 2 years. So I know that's one that we want to kind of delve into a little bit. But I guess taking it up a few thousand feet, what are the changes that any of you are seeing from a commercial plan perspective or a state delivery systems perspective that either offer the most hope or the most challenges that might not be obvious to a commercial health insurance member carrying commercial health insurance? So let's kind of open it up and we'll start there and kind of drill down into some of the topics. So any that stick out to any of you that would be impactful or either a good way or a concerning way? Dr. Worth?
So thank you for having me. And, Kaiser Permanente, like I'm sure all of organizations are really seeking to understand the rapidly changing kind of federal announcements and what that means for us, what the executive orders mean for our organization and what we can expect to continue. But, we're monitoring a number of significant trends, and I'm happy to speak quickly to maybe three trends that are concerning and three areas that we think offer some hope and solutions in this conversation, specifically first around access and cost in our commercial plan members. I think the first concern that I would bring is the enhanced subsidies and premium tax credits that ended in December. And to my knowledge, Congress hasn't chosen to extend those yet. And so we all know, I think in this room, that expiration, it makes it harder for patients to afford care. And so then that means more people are going to go without care in the right setting. And we've been down this road before. And that means that those delayed needs of healthcare come in the emergency department and other places down the road and ends up costing us more down the road. And so I bring that up because that's something that's going to, impact costs for everyone and cost us all more, including commercial members. I think the second thing is the U.S. population is aging at a significant pace. I think that's a blessing on one hand, but it also historically, without innovation and changes, that's meant more healthcare needs from our seniors. And then the third thing is we just have to call it out. Patients, even younger, are seeking more healthcare than previous generations. And I think there's good and there's good parts of that. And it just means that there's more care, particularly chronic disease and particularly mental health. So those are maybe three things that we're looking at impacting commercial members. I think three solutions that I'd quickly speak to. First, prevention. I'm going to be your guy that's going to talk about prevention. When we miss screenings, when we're not managing chronic conditions well, it costs us more down the road. So the quick example, some of you I recognize, you heard me say, a few weeks ago, is like when we catch colon cancer early. And this happened for my mother. She was caught at an early screening age, and she had a quick surgery. She didn't have to have all the other chemo and radiation that might go with it. It's 14 years later, and she's healthy and she's active. That's what we would all want for ourselves, is quick cancer screening. But when we catch it early, it saves total costs of $86,000 per person. And we can do screening in a mail-in fit kit that works for really most patients, unless you're high risk. So these are kind of low-cost ways we can help with prevention that save the system money. And I think the second piece, really right place, right care, right time. And so what can we do as systems to keep our patients out of the hospitals, even though we love our hospitals, but keep that for the people that need it? We want to be healthy. How do we stay out of the emergency department if needed? So how do we get that access to that care? And that includes, I'm speaking quickly, but that includes access to mental health, right up front and easy, so that we can get that care done in the right setting. And then community solutions. I just say we know that a lot of healthcare occurs outside of the four walls of the exam room. And that means, what does that mean for my patients? It means they need safe, affordable housing, access to good food, the ability to exercise and stay healthy. And when we do that, that really leads to lower costs overall. So I know that's one of the big reasons why I'm proud my organization, contributes significantly to this just last year, because that's such an important part of when we contribute to local communities. The local community knows what the needs are of that neighborhood, of that community, and can really pinpoint and make a positive impact. So that's where I'd start answering that question, hopefully with some solutions that could help lower costs for commercial members.
Thank you, Dave. Notably, the sense of community and the impacts at local community levels and how that might be different parts of the state, more rural versus a suburban or urban area, and access and knowing the cultural and the community needs. And then also the younger population starting to seek more care, that becomes compounded with some of the other challenges that we might be facing, right, from a funding perspective and coverage and gaps in coverage perspective. But we'll come back to that in a moment. Others have any immediate thoughts?
Just in terms of some greatest concerns, and just going to say OB3, seeing $1 trillion being taken out of healthcare over the system over the next 10 years. I think the Kaiser Family Foundation, thank you, is estimated like 37 billion of that's going to come out of Washington. And so when we think about where that money is, you may think of it as sort of being a Medicaid problem, but really Medicaid problems don't just affect patients on Medicaid at all. It's money that's being taken out of that entire ecosystem. So the providers, like the doctors, the hospitals, the behavioral health professionals that patients on Medicaid see are the same patients that commercially insured patients see. We think about, I think two big concerns are really access and cost in terms of the ramifications. So when you, I'm going to look at Valley as an example. Valley Medical Center is a safety net hospital. And those of you that are familiar with safety net hospitals, like they'll see anybody. They're not for profit. It could be a community hospital, and Valley is a district hospital. So Valley lost $100 million. I think it was between 80 and 100 in funding for programs. So we think about Medicaid cuts. That could be the actual reimbursement that the providers are seeing. It could also be the funding for federal programs. I know you're intimately familiar with this at this point. So Valley loses $100 million. So how are they going to manage that sort of a problem? Or we'll say any other organization would. So to keep the lights on, you may decrease your staffing or freeze hiring. They let 101 staff go. You may cut some of those lower margin clinics. So, or the clinics that we're seeing a higher proportion of Medicaid patients. So they closed their Kent primary care clinic. They closed their Renton Landing primary care clinic and that urgent care. You may consider cutting entire low margin services. So not just the clinic sites, but an actual service. So they cut pediatric neurology. There's not a pediatric neurologist in Renton anymore. They cut maternal fetal medicine. Or you might cut parts of the actual hospital, those services. So there is no longer a pediatric inpatient service. And so again, it's Medicaid dollars that resulted in those cutbacks, but I am a commercially insured member, and I'll share my own experience. One reason I'm wearing this mask, I was just at Children's Hospital for a week and a half. My 1-year-old had bronchiolitis. Valley Medical Center is my local medical center. It's where I did my family medicine residency. It's where my dad gets cardioverted. Like it's an important for us. The bronchiolitis, for those of you that have little kids, tried little kids, they get through it. You're usually, on oxygen, maybe some suctioning for a few days. But instead of being able to use our local hospital, which we would have up until a year ago, we were driving a 3-hour round trip to see our kid and also manage our 4-year-old at home. And again, as a commercially insured member, anybody's going to feel that effect in that area. Certainly access is a major issue and something that we're thinking about for those services. So ways that they might save, and like we're seeing there, are cutting those services. But then also have to really think about costs and what that means for commercial members. So thinking about like the wait times in that scenario too, you had mentioned how the ERs get congested, I think, in these scenarios where you have less people with insurance. I want to get into costs a little bit. When you have uninsured members, they're still going to use the ER because the ER is not going to turn away somebody because they don't have insurance. That's going to increase the wait times there. That also means that ER is going to be performing more uncompensated care. While they can certainly send that member to collections, it's also likely that they're not going to get any funding for that visit. So it's going to increase the cost there. And that is just going to get passed down. The Washington State Hospital Association was pretty clear last year when they were talking about capping hospital funding via mandate from one group, that they're just going to put that balance onto commercial insurance because it's the one area they can flex. And I want to just highlight that the commercial insurance is a place where folks can flex. When you have a hospital system that has done everything it can, it's trimmed all the fat, they've reduced hours, reduced services, but they still have to do the medicine. Like that medicine still has to get done. It still costs something to do that medicine. If they can't negotiate with Medicaid, but the one place they can negotiate for higher rates is commercial insurances. And so that will get pushed onto rates for commercially insured members. I'm very concerned about that.
Great points. And one thing that I would highlight, I think is a really important one, is this notion, regardless of which line of business, whether it's Medicaid, it's Medicare, it's commercial, we're talking about, often we hear about the shifting of the pricing because, one pays lower than others and they've got to make that up somewhere to meet in aggregate, the bottom line. But as folks move from, exchange to perhaps Medicaid, perhaps to uninsured, because of those funding changes, you've also got this exacerbating problem of, because I'm now uninsured, I may not be going in for the care that I need, and that's going to cause a larger problem down the line, more complications by the time I do get in. So it's going to be even more costly. And to your point, at some point, the care has to get delivered, and it's how will that funding flow back through from the pricing for the providers? Because as you said, they've got to stay in business, and they've got to figure out a model in that new environment, if you will, that they can sustain.
I think, just to jump in on that point and some of what you were just noting, from the Department of Health's perspective, we have a statutory obligation to manage our state's charity care program. And so about 51% of Washington residents are eligible for charity care here in Washington State. And with about, I think the estimates are 300 to 350,000 people maybe losing their insurance or having to make significant changes. We do expect charity care to increase at a pretty significant rate here over the coming years. So that, I think, as you were articulating, has an impact on hospitals who will either have increases in bad debt or have to provide more charity care to community members who are coming in. I think one kind of more granular kind of thing that we see also playing out that you were touching on is, I think both of you touched on, as patients are no longer able to get preventative care, they're going to show up in our hospital EDs. I think what we've experienced, 2017 was a really challenging flu respiratory season for us here in Washington State. We obviously then went through COVID in 2021, 22, which significantly strained our healthcare system. And in Washington State, we have fewer beds per capita than many other states. So when we have strain within our healthcare system, it puts more strain on our EDs. Patients are staying there longer. We're not able to move them through the facilities to get back out into the community. So we do anticipate greater strain on hospital EDs. We have some mechanisms at the state level to try to reduce that strain, but those are somewhat limited. And I think within that, we also have seen impacts when our hospital EDs get strained. We see direct impacts on our EMS and our communities. EMS is taking patients to hospitals. If hospitals are not able to take those patients from the EMS community or providers, then those EMS providers are waiting at those facilities for longer and longer times, which then directly impacts, their response time in communities. So it really is, I think, a lot of dominoes that then start to fall that impact, several parts of our system. And so those are some, I would say, kind of more macro changes that we see happening kind of in the hospital landscape. I think there are some broader changes and challenges that we're seeing that maybe I'll save for kind of later on. But yeah, I think just tying to some of the points that you guys already made.
I just wanted to add to that I'm sure it's not nobody's missing the irony here. Like, the irony is that as we lose funding, as healthcare becomes more expensive, the reaction is to use more expensive healthcare. We were just mentioning it, that EMS shouldn't be involved if at all possible, right? But as people lose their transportation or their ability to access care, they end up in the ER more, they end up in the hospitals more. And the cost there is dramatically greater. So David mentioned it already, and I do think when we're talking about solutions, there are a few in a context where there's billions of dollars being pulled out of the system. The solutions are elusive. But again, it comes back to you said prevention, and I cannot emphasize enough how much prevention stops the process, stops the problem before it happens. But it requires investment, and investment is a hard thing to consider when money's being taken away. Investment is something you tend to do when you have extra money. But in medical care, prevention is not investment, it's medical care, at least to doctors like us. So prevention, and then David mentioned right care, right time, right place, the correct care for the condition that is there. And a good example is your mom. So the correct care was screening and then early treatment, so that the correct care was vastly less and much less damaging to the patient as well. And then community investment. So I think there's some solutions. It's a question in my mind is, do we have the focus enough to say it's what looks like investment is actually still just medical care?
Thank you. Want to circle back to Dr. Ward, one of your comments about younger folks are seeking more care, and this might be my being naive. Is it correct to think that younger population, as they're beginning to engage and seek more care, it's more of the preventative care based as opposed to chronic illnesses and acute needs for interventions, or is it more complex than that?
I think you are right on. It's a little bit of both. And so, yes, we're seeing more engagement in that upstream care, especially around mental health. So younger generations, and this is just a generalized tone, there's differences for every family and everybody, but in the most part, I think the younger generations are much more comfortable talking about mental health, acknowledging that it's something that impacts them and reaching out for care. I see that as a good thing, right? That's a wonderful piece of it. And like you said, the second part of that, there is more chronic disease. So we're managing little bit of a broader scope of medical conditions that are pretty complex. We might have 20-year-olds with ulcerative colitis or, really complex GI conditions. And when you look at those conditions, what are the treatments? Well, they're very, very expensive biologics for most of those patients, which is why, we could talk later in pharmaceuticals, how we use biosimilars as a cost saving strategy, because we think that's just as good quality, but at a fraction of the cost. But that's an example of how it's both. It's chronic disease. And yeah, I do think younger generations are more proactive. And if I tie it back into community solutions, how do you look to these community solutions to help be part of the solution too? And so, one of my favorite exam room things that I share is if you actually get free access to the Calm app when you're a Kaiser Permanente member. And for any of you, I use the Calm app myself. It's got world-renowned experts that help with like meditation and helping to get to sleep and mindfulness and stuff that's evidence-based that can really help anxiety. And so that's a way to do it in a more cost-controlled way. I'm not saying that we don't need some people seeing an excellent mental health professional and getting those services, but that's kind of the portfolio or the range that we can offer a community that doesn't always just need to be medical care, can be outside of those four walls in what communities provide for mental health and what we're doing. So I think it's so nuanced. I know my answer is like just hitting the crutch because of it, but I think it's both outreach and chronic diseases significantly up.
So if we can shift gears a little bit, something that you just said, and it was mentioned earlier too, by at least two of you, this notion of preventative care at the right time in the right setting, for the right patient, and engaging earlier to get care and doing it more cost effectively with better outcomes for the patient potentially. With some of the dialogue that's going on and the narrative that's coming out right now about evidence-based approaches, and we're talking about screenings, the right screening at the right time to catch things early. I worry a little bit, and I'm curious for your inputs about what impacts that will have on being able to do those screenings or getting the right preventative care at the right time. Vaccines be a prime example, right? There's somewhat conflicting recommendations being made. So how do you see that playing into this? We want people to get the right care earlier and more in a more preventative way. And some of the developments, whether it be around vaccines or it might be some other type of, very specific esoteric types of care with conflicting evidence-based guidelines. And then the add-on to that, which we'll come back to, is what does that do from the movement towards value-based reimbursement for the providers and engagement of members in those kinds of value-based outcomes. So anybody feel free. I know that's, it's kind of I have one question in 42 parts, right? But feel free to take any part of that.
Well, I want to start with vaccines and saying that I'm grateful for Washington State and providing other guidance. So at Regents, we believe in the science and we believe in the evidence. I'll start first with just coverage with vaccines. I mean, one of the more fortunate parts about how some of those changes are written is that they are still recommendations with shared decision making. There are regulations that still require those to be covered at no cost sharing even if they're with shared decision making. We also consider those recommendations to be the floor of what can be offered as preventive vaccines. So we are grateful for other recommendations that are science-based from Washington, from the American Academy of Pediatrics. We will look at it all. As far as the ability, actually, what would you like to tackle next?
It was also the ability of kind of in a roundabout way I'm trying to drive at. What's the performance metrics that we all look at within the industry? We look at things like HEDIS measures to gauge how effective is the care being. When we look at a value-based arrangement, we're looking at quality of care metrics and outcome metrics typically to see how effective the model is. And as we have these, I would agree with you that having an engaged conversation where it's shared decision making, that's kind of a holy grail for all of us in this industry, right? But where there are conflicting pieces of guidance, potentially conflicting, I worry a little bit about what will that do to degrade the overall performance within the markets, and what will that mean to the population, in this case, in the state of Washington.
Right. And I understand that concern. I think I might have to speak from just the region's perspective on that. So I will say, and I'll defer to some of the more active providers, I mentioned coverage still being consistent. We still see questions from patients where they say, my doctor told me they weren't really sure if my vaccines would be covered, and so they didn't do them. Can we find out? It's clearly causing confusion. And like that of course is not going to help outcomes one bit for the physician or for the patient. So we've been doing outreach to our members and also to physicians to try to clarify whether we still cover it. In terms of looking at outcomes. So there have not really been any significant changes to HEDIS measures yet. Will that come? Anybody's guess, but we're concerned about it. When we think about value-based contracts, which are really based on outcomes, and the work to prevent negative outcomes, like really those should be, and I think will continue to be, like evidence-based outcomes, where like if we have some guidance that comes from somewhere that doesn't actually improve somebody's health, keep them out of the hospital, or prevent disease, that's not an outcome that we would, you would reward in a value-based arrangement. I would imagine, I mean, that other health plans would look at it the same way, that if it isn't actually saving them funds down the road to have a value-based arrangement where there's not a good outcome on the other end, there's no value being created.
Maybe just jump in here from a state perspective and, looking at, value and making sure the patient gets the right level of care in the right time. A trend that we have continued to see is a contraction from care in our rural communities back into urban settings. It's, I think, very evident right now in the movement of dialysis care outside of rural communities into urban centers, which means that patients will have to travel multiple times a week to receive their care. I think we've seen that same trend in other services. We've seen OB closing in rural communities, which directly impacts younger families. And then other services that have, again, continued to contract, which just puts a further strain on our rural members of the community. I think, another trend that we've seen that again, this is higher level than kind of individual patient perspective that I think will impact, value and metrics over time is that the state has a process for allowing healthcare to be established here in Washington State through our Certificate of Need program. About 25 states here in the United States have it. And it looks at kind of longer trends in terms of the healthcare marketplace. And with changes at the federal level, a lot of unknown tariffs that have been put in place, we've seen a lot of contraction of entities looking to establish new healthcare facilities. So that's, I think, a longer trend if we think about, having the right structures in place for patients to access care. If facilities are not thinking about expanding now, in 8, 10, 12 years, we're not going to have the infrastructure that we need in our communities to provide the right level of care in the right time. So that's, I think, just a longer term trend that we are concerned about. And at the state level, I think there's challenges in what we can do because we're not in control of tariffs and setting federal policy, but it's directly impacting our long-term trajectory and stability here in Washington State.
Dr. Ward?
Yeah, so I just wanted to circle back to vaccines. Very passionate topic for me. I'm a father, I'm a physician, and at KP, we believe in keeping people healthy, not just treating them when they're sick. So we have not changed our vaccine recommendations at this time. Our expert physicians continue to look at, everything that's out there from a scientific community, like American Academy of Pediatrics and many of the societies, and look at that. And I think the story that I would share here, so it's crazy to hear it coming out of my mouth, but I'm now 20 years into medicine. I've always believed in shared decision making. That's kind of the oath I took. And so from the time I came into medicine, there's been patients that have had concerns and questions about vaccines, and that's always been a part of the exam room. And I've always considered it an honor to first build trust with my patient, understand what the concerns are, really go through some of the why. And, now that I'm a father, I can hearken to some of my stories, why I chose to have my 2 kids receive all of the vaccines. And I'm very happy with that decision. And I'm very grateful that that was available to me in this country. But I can talk through, I can build that rapport, create that environment. And oftentimes that then leads to patients making a decision that, from my perspective, leads to their best health, and usually is to get the vaccine. But it's done in a collaborative way. I often tell patients, I'm your coach, I'm your biggest fan. What do you need to know? What information do you need to be able to make the right decision? And that's the thing that hasn't changed in all this. Regardless of what you look at, shared decision making is there and should be a part of what we do in healthcare. So that's what I wanted to add.
Great comments. Dr. Ankeny?
I just wanted to talk a little bit. You mentioned screening and how to better implement screening. And I thought what occurred to me was just considering paradigm shifts. Just think about shifting the paradigm sometimes. So the two tests that come to mind for me when we're talking about that kind of thing is, for example, colon cancer screening historically was a colonoscopy, and still is. That's still the standard of care, but it turns out it's one of the standards of care now. And a colonoscopy has not insubstantial risk associated with it, aside from the fact that it is also expensive and it's invasive. And it turns out you can also screen for colon cancer with a very, very much less invasive, we call it a FIT test. You just take it home. It actually comes in the mail and you do it at home. And cervical cancer screening, same thing. And I would joke with my patients when we're doing pap tests that if I could think of a way to get this test done differently, I'd probably be a very rich guy, because pap test is uncomfortable. It's all the things that people dislike about having that test. We all can imagine what those are. Well, that's out there now at a fraction of the cost, and it can be done at home as well. And very easy. You just read the little instructions. You go step by step. You put the thing in the mail. You send it back, and you have the same level of screening at about 1/100th of the cost. So that kind of paradigm shift, when we're looking at, and we're trying to think of solutions, how can we come up with things that are going to improve our screening, both from a compliance perspective, but then also from a cost perspective, especially in an environment like we're sitting in now. This is the kind of thing that that offers some hope. Because for many people, a lot of this is still just education. People don't know there's an alternative to a colonoscopy. But would you like one if it was easier and you could do it at home and nobody had to get involved with your business and you could just get it done, right? And most people say, well, tell me it's actually as good as a colonoscopy. And yeah, for sure, I would do that. So there's hope out there, especially for screening. And these kinds of things are emerging consistently now.
So someone brought up well, a couple of folks brought up the T word, tariffs. Let's talk about that for a moment. I'm particularly curious thoughts on impacts of tariffs for availability and pricing of pharmaceuticals and durable medical equipment in particular, for things that are often, not always, but often manufactured outside of the United States. And what impacts do you see from a care perspective for those things starting to manifest themselves?
You just asked 3 doctors about tariffs.
And realizing that I am the economist in the room,
Yeah.
Which is probably why it's more interesting to me than many. But yeah, I mean, you don't have to think too far, right, about access and cost will be impacted, or it will drive where they're sourced from, right? And it plays into this notion of direct-to-consumer federal pharmaceutical programs and perhaps drug price negotiations. But Ian?
Yeah, and I can't speak to the impact on medical equipment or pharmaceutical costs, but again, going back at least from the Department of Health's perspective, through our state certificate of need program, which if you're an ambulatory surgical facility looking to open up, if you're a hospital looking, most hospitals, not saying new hospitals, but if you're looking to remodel, renovate, you have to go through this process. I mean, we're seeing swings within days of new tariffs being announced, of entities pulling back their plans for development that are usually sometimes, again, 8 to 12 years out. So, I mean, there's significant, swings that we're seeing within that. We're seeing pretty substantial cost overruns when entities are building upwards, to, multiple millions of dollars as the cost of steel swings rapidly within the marketplace, which again, any business needs consistency to operate. They need to know kind of what the environment is going to be like in the future so they can plan for that. And right now, I think in the healthcare environment, it's hard to plan what your costs are going to be if you need to build a physical structure. And so again, just acknowledging that from some sides, the tariffs are having daily impacts in terms of what entities are planning on doing. And I think our concern is that several years down the road, we're not going to have the level of services that our communities need as the population continues to increase, as demands are different. And so I think that's that longer term impact that the tariffs will have here in Washington State.
I appreciate Dr. Ankony's levity because I just want to make clear I'm a physician and not the most qualified. Do have maybe a couple talking points. Had to do some homework on this. Remember, at Kaiser Permanente, we do our pharmaceuticals different. So we don't have some of the third-party involvement. We use essentially our size to negotiate big national contracts to lower cost. So that when we checked in with those people on that piece, our largest exposure to tariff costs, I have it in my notes here, is from some of the impacts of pharmaceuticals in India. Right now, since a large portion of our generic pharmaceuticals are manufactured there, we haven't seen much risks of tariffs on that. So for those two reasons, kind of the way we nationally negotiate our pharmacy and a lot of our generics are in India, we haven't seen initial kind of changes in our pharmaceutical related to tariffs yet. As far as medical devices, a similar nuance, we have like a long-term contract strategy. And so we're in the middle of that right now. So we're not seeing that yet, right, as in 25, 26. But we are under any illusions that once that contract comes up, that then the cost of some of these materials, like my colleague is saying, is going to affect. So while I'm not seeing much of a change in 2026, according to homework, definitely see it on the horizon for medical devices.
I think there's been some news that might like play into that a little bit. Like Johnson & Johnson reported that they paid about 400 million in tariff related costs, and that's going to reflect in like sutures, knee replacement parts, etc. Like just some of those basics. Once more, this kind of comes from homework. I was thinking about, like you mentioned with pharmaceuticals, we think, oh, well, we'll just have more domestic medications, they'll be less expensive. Well, with even domestic manufacturing, so we can source like the gel and the gel tabs and we can put it together, but about 85% of the active ingredients, the medicine that actually does the medicining, comes from abroad. So even when we're producing it ourselves, most of the expense of, actually it's between 25 and 80% of the expense of making the drug is still materials that are brought in from elsewhere. So something to keep tabs on.
And in that vein, no pun intended, with direct-to-consumer pharmaceuticals, any initial thoughts on how that would play in the market for a commercially insured member, if they were to choose to do that for a drug that's being negotiated, the pricing is being negotiated at the federal level, with the thought being obviously that they could be more effective given the volumes and driving patients into, those specific arrangements. Just initial thoughts.
Yes, can I jump back in? In reviewing what some of those rates have been that have been negotiated for Trump RX, they're not that different than what health plans have negotiated. So I think if you look at a price, like I'll use Advair, for instance, like the MSRP on Advair is like $280. And on Trump RX, it's like $80. That looks like a fine deal if you're not using your insurance, but that's similarly priced to what a health plan would be able to get it for. And the patient cost in that case might be, say, $3. That's actually the average for how much Advair costs a patient with insurance. Now, I understand that folks have high deductible plans, so they might still be paying the $80, but the benefits there is going through their copay. Also, their health plan knows what medication they've had and what they've refilled. When you go direct to consumer, that information is lost. And health plans may use that information for particular drugs to say, like, oh, we've noticed you haven't picked up your anticoagulant. You might want to look into that and understand if you're having an obstacle or you stopped your antipsychotic. Health plans follow HEDIS measures, like specifically about some drugs. Like we want to know, or we're trying to make sure that our patients with heart disease, our members with heart disease, are taking their statin. One of our quality measures is looking to assure that our members with asthma are using their controller medication, proportionately to the rescue medication. If they're taking the rescue medication constantly, we know that their asthma is not well controlled, and that's an opportunity for our care managers to reach out and help them connect with resources to help their control. With direct-to-consumer pharmaceuticals, all that is gone.
Yeah, I just want to, I just appreciate what you're saying, Dr. Jones. What's running through my mind is the direct-to-consumer thing, is probably just going to shift profits to in a different direction. It doesn't look like so far in the early running, it's actually delivering savings downstream enough to be received all that well at the patient level. But B, the big one that comes up for me is that it's a major patient care issue. So there's a disconnect now between the person, the group giving the medicine and the people that are actually caring for the patient. And as as family doctors, I mean, we're whole person focused, and it's extremely difficult to find that there's a channel that is disconnected from me that's medically active that I'm not managing and I'm not seeing. And those people, those organizations that are directly giving medicines to patients don't fall under the same quality measures and quality standards that they should be, especially from a state perspective or from group perspective. So I think it's, at least as a doctor, I think as a doctor, I'm very displeased with that focus, especially because I don't think if it was going to be a big savings, then maybe, but I don't think it will be. And the other point I wanted to make is that David kind of mentioned it, but nationally, Kaiser Permanente has 12 million members. And so it allows for broader contracts, longer term contracts, negotiations at scale that can withstand fluctuations in the market a little bit. So bigger tends to be better. I heard there were tariffs 2 days ago in Europe, and now there's no tariffs today. So, or I don't know, actually, it's morning now. So maybe maybe the tariffs are back. I don't know.
Check
But-
multiple times.
Yeah. It's just, you kind of wait. But I think the upshot here is that stability is achieved by there is a stable factor kind of holding on underneath the churn that's going on up above. So things are still shaking out, and they're really active right now. So there's hope.
So also circling again back to something that has been said numerous times with transitions in coverage, for whatever reason, right? It's not unusual for folks to transition from one type of coverage to another. And when I'm saying types, I'm not referring to the actual plan they're covered by. I'm referring to the line of business. So someone would transition potentially between commercial coverage into exchange coverage, maybe from exchange to Medicaid to uninsured. As we see funding impacts and some of that shifting happening more quickly, I was reading a report last week that it's roughly 1 million members a year see some type of transition like that. And the question that was raised was, is there likely to be a longer gap in the coverage change? Will they stay uninsured longer? And it gets back to one of the things we were talking about at first, right? That if someone is uninsured and they're delaying care, deferring care, ultimately they may have a more complex issue when they do go seek care. But any thoughts about the length of those gaps and the potential clinical outcomes impacts as we move forward into this sort of brave new world with funding?
Yes.
Would you care to share them?
Yes. The upshot is there's a major concern there. And 1 million members, 1 million human lives. I think that's a safe estimate. I think that's probably low. And it's, again, I'm a practicing physician, and it's tough on the member, and it's also actually tough on the care provider, especially if there's an in and out flavor to the whole thing, where they're with Kaiser Permanente, then they're gone for 2 years because their job changed. Now they're back with Kaiser, and I will broaden that to say for any doctor, it's really hard to pick up the pieces because that's what you're doing. And in the interim, typically where they went was somewhere that required them to, these patients to access the system in a more expensive way, like we talked about earlier. They don't have the same access that they had. They don't have consistent primary care access. And so they're going to the emergency room, and they're going to emergency rooms that aren't in any sort of unified healthcare health record. So I'm not able to see what happened. I don't know what happened during that previous year. And oh yeah, I forgot to tell you, I had that pulmonary embolus. Did I mention that? I didn't mention that. Like would have helped. Would love to have heard about that. And that happens an enormous amount of times, as well as it just more people end up in the hospital. So. I'd love to see some sort of a system put in place that helps to mitigate people who are at risk for those transitions, potentially seeing that in a short term, there's some sort of bridge that would allow them to stay consistent with their primary care. irrespective of which system they're in, if they're with Kaiser or with whoever. I'm just speaking as a doctor. There's, again, it's an outcomes and care focus that says this is a huge risk, that kind of upheaval. And we're the worst for it as it is.
And Dr. Ankeny, I appreciate you bringing that up, because one of the things that I think about in that context is, as folks have those changes in coverage and the coverage gaps, there's the continuity perspective that you just called out. You articulated it much better than I would have, of being aware of what's gone on, what's happened with that patient, what are they likely to have, be facing in the future, and just knowing them. And you're kind of resetting in many cases, because you have to change physicians sometimes when that care, or the coverage rather, changes. Ian?
And I was just going to kind of even jump in on that point. One thing that we have seen at the state level that is some concern is kind of their shift back and forth is just the network adequacy in communities. And, as people moving back and forth, is there sufficient coverage as people are churning through a process? And then even I moved recently in the last year, and I was trying to establish a primary care provider. It was like 8 months before I could get in. And so it's just, as there's change and people are moving, I think that's just from a personal standpoint, I think it's going to be more and more challenging for people to get in and see and establish with a new provider. And that's where I think is some of the comments made earlier, people are going to, and others did, they're going to end up in the EDs. We're going to see an increase in hospitals providing charity care to patients who are in that gap period where they don't have coverage for a particular period of time, which has impacts on the broader system.
Any other thoughts on that before I kind of bring us home? We're all good? Okay.
John, I'm just going to flag for board members, when we get to the legislative update a little later, this concept of the impacts of insurance churn and the waits and needing to establish care, and, a new provider, a new PCP won't necessarily sign your prescriptions because they haven't met you for the first time. All of those, there's an undercurrent of one of the bills we'll talk about that's intimately related to this churn effect. So just wanted to flag that as a breadcrumb for a little later.
So I guess my question, just to kind of sum things up, and I appreciate all of the thoughts and the insights that you're sharing, would be anything that we're missing, not thinking about, that when you think about some of the more obtuse impacts for a commercial member of changes that are happening in Medicaid and exchange, and these transitions between types of coverage, or the approach to providing whatever the service is, whether it's the clinical service in the office the setting, or it's pharmaceuticals, or writing a prescription for durable medical equipment, whatever it might be. Are there things that we haven't talked about that you think are worth noting for the board members as they think about what are the pieces of business we have to do for school employees over the next year? I just open it up.
I would flag rural. So I think that's a massive, I think it's a greater kind of risk as we go forward for a lot of reasons. We've got a lot of studies that show that Medicaid, creates healthier communities and as an economic support. And there's a lot of pieces of that. And as we are concerned about, access to Medicaid in the rural communities, I think that the struggle is greater to try to get the care they need from a variety of things. Many of you know, or may know, I live in Spokane. Spokane's a city. We have Trader Joe's, 2 of them. But, I see patients that drive hours from rural communities to see me, and they do it because of, a variety of reasons. But so when they're coming all that way, I'm quickly realizing they made a choice. Is that choice to invest in the gas money or whatever to do that they may or may not have, or to get the virtual care that they may or may not have with a smartphone or Wi-Fi. There's unique different hurdles in rural care, not to mention that there are fewer and fewer specialists and primary care clinicians living in rural communities than ever before. So we're seeing, extreme pressure on hospitals and systems in that rural community, forcing people and then even, without Medicaid access, to make very difficult decisions. And let's face it, we know that there's generally more poverty and more chronic disease in these rural communities. So healthcare needs are greater. So I just flag that as almost a greater risk in our state of patients getting care with some of these changes.
I'd like to just plus one that one with the risk to rural hospital. So sort of what I was talking earlier about the risks of services that are strongly dependent on Medicaid right now, how that affects everyone who goes to get that service. 1/2 of the deliveries in rural areas are with to Medicaid mothers, and so OB services may be significantly strained down the road.
And I mean, I just jump on that rural point as well. It's, there's a couple other comments I've made, spoken to kind of rural communities. The Department of Health and other state agencies have been working closely actually with one rural hospital, East Adams Hospital. It's public. They've been having significant financial challenges. If that hospital were to go under, that community of about 10,000 people would be over an hour for them to access the closest facility. And that community would also lose their EMS because the EMS is tied to the hospital. So I think there's, a handful, about 5 other rural hospitals who are financially struggling. So again, I think that importance of focusing on rural communities, because with HR 1 or the One Big Beautiful Bill and cuts to Medicaid, that's going to have a serious impact to our rural communities. I did want to end on, I think one positive note. I think you also spoke to some positive things too, but one positive note I think I would say is, we can do difficult things in the state. One bright light that I do see is around access to behavioral health or mental health services here in Washington State. My office, we regulate over 13,000 different healthcare facilities. A good size of those are behavioral health facilities. And as a state, we've made significant investments into behavioral health, from capital dollars flowing to build new behavioral health facilities. And obviously there's a tremendous amount of work to be done, but it is promising to see, new facilities coming online, new concepts, access to opioid treatment services continue to expand to be in kind of a more of a mobile setting. So that is one bright spot that I do see of, when confronted with challenges in our state in the behavioral health arena. I think collectively we've made some significant investments and are starting to see some of the impacts of those investments. And so I'm hopeful, we'll continue to see that in the behavioral health space, but also in other spaces as well, as we kind of as a state look to focus and narrow in on where our priorities are. So that would be the one positive thing I think I would leave us with, that we can do difficult things when faced with challenges.
I would just say, Ryan, it made me think when you were talking at the beginning about how you have a family of educators and this is close to home. My eldest daughter's boyfriend came to me and said, "How would you feel about me marrying your daughter?" And I said, and what I thought was, he wants to be a teacher. And I thought, okay, well, they have good benefits. You should be able to take care of my daughter. So I care. I have my own, get this right, because he's coming for you guys, right? But you're asking kind of as a board, and I think what I would say is, broadly speaking, there's 2 systems of medical care delivery in America. There's fee for service, right? And there's outcomes based. And fee for service effectively is enriched by illness. That's the fundamental design. There's no value in a fee for service system unless people are sick, because they have to come and pay for their illness. Outcomes based is exactly the opposite. When you think about the downstream effects of that economically, as well as for me as a doc, as for health, outcomes based is just vastly more powerful. And so my humble suggestion to you as the board is to have in your mind, as you're evaluating policies, bias your thinking toward the policies that are outcomes based. Those are the policies that are going to be the best for cost, and ultimately they're going to make guys like me happiest, because that gives me the power to take care of my patients the best.
And I'd just like to close with a comment that was raised numerous times, and I really appreciate this being brought up, that we've shared with various conversations over the last couple of years with both boards, the notion that when we say rural, if you live in the city of Seattle, if you live in Tacoma, if you live in Spokane, you might have a preconceived notion of what rural means, right? And that it's not one of those major urban centers. But the challenges that are faced in each of those rural communities, to your point, Dr. Ward, is very different. If I think about someone in the northeast corner of the state, in the winter, their ability to get to a primary care doc involves a plane flight, right? Because they can't physically drive over the mountain, even if they wanted to and had a car to do it. And so being cognizant of, we serve members, whether it's in Medicaid, whether it's in the exchange, or whether it's in our commercial, public employee and school employees benefits that are in very different situations and facing very different challenges. And I think that's important for all of us with the board to keep in mind as we go through our business this year. So. All right, well, gentlemen, I appreciate all of you being here and participating. Any questions?
John, I think we have a question from
Oh,
board member.
yeah.
Just a comment about that. Not just the rural aspect of it, but the economic pressures of the community as well. I live in a community that has a very high military population. Several years ago, the Naval Hospital in the area decided to close their OB services. So that put all of those OB services into the local clinic in the area. They faced some dire economic pressures this year because of the just, volume of the number of patients they were added into their caseload. And ultimately, the tribe had to come in, step in, and took over the clinic. So just some other economic pressures that are, within your community as well, not just the rural aspect, but you guys talked about prevention, and ultimately with prevention comes access to care. So if you can't access care, can't see prevention. So
I think question from Pam, then Allison, I see.
Well, John, I just want to say thank you for this panel discussion. We've done this, I think, several years now. This is one of the most engaging and timely discussions. I can say as a teacher, I didn't zone out. My students know I'm really good at it, but no, this was related to everything that we are dealing with. I'm messaging with teachers back in my building. They want to know what the legislation looks like. So thank you. This was like the right panel for the right time.
Thank you, Pam.
I wanted to just make a couple comments about rural health. I too am from Spokane and can attest to what a great pediatrician Dr. Ward is, because he took care of my kids for a while. So we've had a fun reconnection point here, and everything he said about how he approaches his care is 100% true. I think in addition to rural communities having challenges with the set of services that are available and the financing, in Eastern Washington, being on the Idaho border, we are also seeing a lot of people from Idaho who need care coming in. And because for some folks, it's not safe to get care in Idaho, and for some, they just need care and they've given up. In Idaho, it appears that way. So when we think about this as a system and how we need both Medicaid to be paying our commercial players, and where Medicare fits into this, I think there's just another dynamic overall. I also want to really highlight the role community needs to play in this, and that, of course, we all know 80% of our health doesn't actually happen in a clinic setting. It happens because you've got safe housing, access to food. And as we see those resources being even further constricted, how important payer relationship with community is, provider relationship with community is, and that we're not duplicating systems that already exist inside the community. So I just think as we're keeping these trends moving, we've got to be so much more efficient in how those types of referral relationships are happening and people are getting care. And this circling back to, wouldn't you like to know if one of your patients has said, I don't know if I'm going to be able to pay my rent next month, that they indeed got connected to someone who helped them get their rent paid so they could get back to focusing on, whether it's their disease management or just their prevention activity. So I think we got a lot of work to do on how the bidirectional flow of information goes as well. But thank you. I would agree. This has been an excellent, excellent panel.
Other questions, comments from the board? Yeah,
Hi, thank you so much for your panel. I think John asked this question, but I wanted to pin it down a little bit more, especially with 3 medical directors here. The evidence base is always changing. So as federal recommendations potentially start to scale back or go against evidence-based recommendations, those are tied to what you can and can't pay for, or the insurance companies will cover. So as you are thinking about this as medical directors, should the evidence base from the preventive health services at the federal level change in a way that scales back and it goes against the evidence base? What is your commitment as insurers or providers of healthcare to stick to that, which is the evidence base? What recommendations are you going to be following into the future? And then I guess the second part of my question is, can you give some specific examples of how you've been messaging this to providers and patients? Because we're going to be thinking about this as our as the plans that cover our members for this board, how this information gets back to them as well.
Just want to start with a quick one. So one place where we've highlighted this and actually put pen to paper is in our contract language. In our contract language, previously, where it would state that our vaccines are, and I won't be able to quote it, but essentially that they are taken from the USPSTF and ACIP. The language is getting updated to list that they are evidence-based and derived from, and then a list of various professional societies. So the American Academy of Pediatrics, the American Academy of Family Physicians, et cetera. And so we're broadening the evidence base that we're saying that these recommendations are coming from.
I get the sense time is an issue. I'll give a very concrete example like you asked for. I track all of our physicians on when a patient comes in, let's use a child, for example, what vaccines are due and what % of the time we're getting those vaccines. And so we track that data and we publish it among our clinicians, and we have all sorts of, kind of fun ways to say, how can we get that number higher and higher and higher so that when a child comes in, they get the vaccines they're due. And we have not changed our vaccine guidelines at all at this time. So we continue to look to, groups like the West Coast Alliance and, like I said, the American Academy of Peds to keep looking at those. We haven't changed our guideline, and we'll continue to track to that clinician by clinician to get those rates as high and high. That's why I spent time on my story talking about the trick is, as more and more patients have concerns, which was always there, but now I see that ticking up. I see that ticking up in Spokane. How do we get better and better at using our trust and a relationship for that shared decision making? That's why I chose to use that story, because we're talking about it as clinicians. Like, hey, how did we explain why your baby should get that hepatitis B, vaccine? What are the pros and cons of that? How do I talk that through with that mother and father who have really real concerns, and I value their concerns? So how do I do that in a trusting way?
It may sound a little strange, but the recommendations from the federal government are actually now in the minority from the organizations that also recommend on these issues. And so it's kind of easy to just go with the majority, right? We're using the American Academy of Pediatrics, the AAFP, the Family Medicine Academy, the West Coast Health Alliance, which was kind of an ad hoc group during COVID that we just sort of got the band back together once suddenly, the CDC started, kind of surprising us. So we're just deferring to the organizations that have been stable for many, many years, and we feel very comfortable with that. And I think most plans are in agreement that we're gonna go ahead and fund those things that have consensus in the recommendations, and we'll let the federal government come back around in time.
I appreciate your answers. And if you could circle back to the second part of the question, how are you messaging this specifically to providers and those covered by the insurance plans? I'll give you a specific example of I am covered by Regents under PEB and work at the University of Washington. But even the University of Washington, when they offered flu and COVID vaccines this past year, said, check with your insurer for COVID vaccine recommendations. We are not sure if it will be paid for or not. So that was a major health system, wasn't sure whether or not your COVID vaccine. So it was then the information gets passed on to the individual. The individual has to call their insurer, and you have to be very motivated to sit and wait in line and make that call. So what are steps that you would like to take or have taken to make that information more available of what's covered by these plans as preventive health changes are being made?
Well, one thing is I think we're trying to socialize or publicize that our recommendations aren't changing. Because that is part of the problem. It's a perception on the part of, say, the University of Washington. Like, we don't know what's happening with the insurers. We're not sure. So you got to go back and check. And so we're trying to make sure that people hear that our recommendations are still the same as they have been. So I think that message needs to get out more and more on a public level.
From a tangible standpoint, patient comes in, we're going to print out that pre-visit summary that has all the vaccines you're due for. And the staff are empowered to ask you, like, hey, due for this, this, this. And I have not been seeing, at least within Kaiser Permanente, these kind of coverage things. We're full on board, trying to get those vaccines to our patients and cover them. I would say the exception to that has been RSV for seniors. And so that's what happens. We have this thing, we call it OPEX. It's a way for the front line to kind of escalate issues. So the front line said, hey, we had a member that came in and said, hey, I got stuck with a bill on RSV. So then that goes up to senior leadership to figure out exactly what is the pricing information, get that back out to all our teams so they have that assurance when they work with patients, like, hey, this is the potential cost, with those vaccines. So I appreciate the question. It's a very real concern. And that's what we're doing about it, first of all, from a clinical standpoint, to our power teams to give the vaccines. And when those cost issues come up, make sure that our teams have that information in hand to be able to help patients with those decisions. Thank you.
Omid, I just wanted to add that maybe 20 minutes ago, before you asked your question, I wrote down, look at our opportunities and communications to send more direct mailers from the healthcare authority to all PEP and SEB members that outlines coverage.
Right.
Can you get it in a clinic? Do you have to get it in a clinic? Can you get it at a big box store or a grocer? Or and what exactly is covered in looking at the seasonality of certain vaccines versus general vaccines and see what other central communications. I just wanted to flag that that's something that I think we have an opportunity at HCA to do a bit better, as this has just become a bigger issue in the last year or so.
Agreed. And the other thing I would note, and I think this is coming later in the legislative update, is work that the governor's office and the Office of Insurance Commissioner have legislation in front of her to serve the protection and preservation of preventative services, which we'll hear more about, sort of leveraging, as Ian mentioned, the health department to sort of be our guide in that realm. And we'll talk about that a little bit later. So thank you. Carrie?
I think as we try to think long-term policy, as we have more impediments to being able to practice evidence-based medicine, and that I think has implications for the kind of contracting we can do with our healthcare, with our insurance products, because we've spent a lot of time trying to build performance-based contracting, where it's based on outcomes, it's based on performance, it's based on standards of care that we know are evidence-based. And as the scout around this disappears, how are we going to be able to continue to try to maintain the quality of healthcare and what gets paid for and how it's delivered and how it's accounted for and what's measured? And I think this just makes it more difficult.
Carrie, maybe just quickly on your point, I totally agree with what you're noting, kind of the scaffolding around us has kind of been eroded. I think several have noted the West Coast Health Alliance, where several West Coast states have come together to say, with the erosion, how can we help step in and provide clarity? And obviously a lot of work to be done there. I do think there's also other examples where we've seen potential erosion and the state has stepped in. So, there was a lot of concern around reproductive services and access to care and what hospital EDs would be obligated to do. And last legislative session, the state stepped in and said, well, we're going to make sure that from a state perspective, we maintain EMTALA requirements here in Washington State, should the feds choose to do something different. And so I think that's another example of where we now have federal EMTALA requirements, and we also have a state structure to say, should there be erosion here, we have a structure that we've stood up already in Washington State to really supersede whatever the feds may do. So I think that's just a model that we could look at as a state perspective as we do see potential erosion in other places. How can we as a state and a collective step in to help make sure that we have that infrastructure that you're speaking to that we need to be effective in those spaces?
I want to circle back and let everybody know that we actually have an article in our February newsletter that'll come out next week around vaccines and confusion and coverage. That's not a one and done, but just wanted to say, hey, it might have been something I wrote down today, but other people on my team were already on it, and that's already signed, sealed, and at the printer. So just wanted to highlight kind of some other proactive things. I know we're near the end of time, but I have always been for the last 5-6 years on a quest to elevate optimism. And Ian, you did a good job of highlighting some bright spot somewhere in all of this. And so I want to challenge the other 3 panel members within 1 minute each to say something really positive about that is going on in our healthcare systems, or just something positive.
What gives you hope?
Yes, what gives you hope?
I think bodies like the Washington State Health Alliance that are, standing up. I think when we have professional societies say something that might be counter to, like we talk about some of the erosion of evidence, like still stand by the evidence and stand by their findings and their recommendations. I think those organizations are all standing strong. So please keep, also I wanted to just to plug, keep mandating. Like we'll cover things that are mandated for coverage. Like keep working on that. We'd love to see more of that, especially if there's some concern about something that may be losing some protections at the federal level. So I'm optimistic about all of you.
I think in addition to what I mentioned about prevention, right care and community health, I mean, just the warmth in this room is a cause for optimism. I'm going to leave here. I'm going to drive down the way to our Olympia Medical Center. We're meeting with the group, and our whole objective for the next couple hours is how can we deliver for our patients the best quality, the best experience, but how can we save our members cost? And one of the topics, there's so many pieces that go into that, but the topic is how do we in primary care do a better job of taking care of our patients' needs? So when it comes to specialty care, of course we need specialty care, but a lot of that can be either done in primary care or at least prepped better in primary care. So when you go to that first specialist visit, you've got the labs, you've got the x-ray, you've got whatever you need so the specialist can make that decision that first visit rather than order more tests and come back. So that's the whole topic. We've got the data down to every single referral. And again, we're not getting in the way of quality or experience, but how do we create a better system? And patients appreciate it. When I, as a primary care doc, if I say, I've got you, I can handle that, and here's why, and here's the backup I have especially, usually that's well received. It saves a copay, it saves a drive, and some of those things. So that's just a small thing in a microcosm of cause for optimism and relentless pursuit of better.
Yeah, I'll just pivot off of what David's saying. The medical system in the past 10 years has become much more specialist dependent than is justifiable from a primary care perspective. So a well-trained primary care family physician can take care of an estimated 85 to 90% of every health condition that a human body can experience. Yeah. That's not where we've been in the past few years. And so I think many health systems, but Kaiser Permanente in particular, has kind of had to repivot back to primary care. We have FTE open for primary care physicians all the way up all the way across the state, actually. And that refocus on primary care does 2 things. It creates that continuity of care that we've talked about and makes that even more robust. But it also helps to thin out the waiting lines in the specialist's office, because we are actually, family docs are able to care for a lot of things if we're given the time and we're given we'll call it top cover to actually take care of that. So that's where things are headed. I'm really hopeful about that. And I feel really good about it. And then our association with the West Coast Alliance, West Coast Medical Alliance is really good, because it's a courageous move in some ways, kind of just saying we're going to not take a whole lot of authority from federal entities at the moment, and we're going to get together with and stay focused on the evidence. So I think there's a lot of hope, especially for the west side of the United States. Maybe it'll even get into Idaho. I don't know. I'm hopeful. I'm hopeful.
Add it to the items in the strategic plan. Again, though, Ian, Dr. Appreciate you guys being here and having this conversation, engaging with the board. Appreciate all the engagement from the board as well. This has been really helpful and insightful from my perspective. So we really appreciate your time today.
Yeah, thank you all so much. I think an illuminating conversation of where we find all of our collective selves in this moment across the healthcare space, So thank you for bringing a lot of that to the forefront and sort of grounding, I think, the board and the thinking and the thought, even as we flow into the next part of the agenda, which is really looking at the legislative portion here locally at the state, and then broader of what's ahead for HCA and the broader boards here to tackle over the next few years. So thank you so much for your time, expertise, and for your good work. We appreciate it. I think we have now a 10-minute break. So we are going to convene here. We're right on time, actually, at 10:40. Started the recording and we're all back up again. So we are going to keep on schedule. And it's a pleasure to invite up Alyssa Richards, our benefits accounts section manager in the ERB division. Alyssa is going to provide us an overview of the results of open enrollment that just completed here in November for plan year 2026. Alyssa, thanks for being here, and we'll turn it over to you.
Great. Thank you. Good morning. My name is Alyssa Richards. I'm the Benefits Account Section Manager in the Employee and Retirees Benefits Division of HCA, and I am here to give you an overview of how open enrollment went.
Have 4 board members. Sorry, didn't say that. Go ahead.
Next slide, please. So there are 2 primary units that are involved in open enrollment in the Benefits Accounts section, the Customer Service Unit and our Outreach and Training units. The Customer Service Unit is the first line of contact for our retirees and continuation coverage members. Staff in our Customer Service Unit, they perform 3 primary functions, which is answering calls via a toll-free line and responding to HCA support inquiries, which is a secure way to send emails to our staff. They provide in-person lobby services for walk-in members and review members' retiring continuation coverage eligibility as they process enrollment forms. So next slide, please. The Outreach and Training Unit provides training and support to agencies and organizations for both SEB and PEB programs, who in turn act as the first line of customer service for their employees. Outreach and Training provides training to the benefit administrators, staff of these entities regarding program plan options, covered benefits, eligibility, rules, and enrollment processes. When these agencies or organizations need additional assistance or have questions, they reach out to our Outreach and Training team through a dedicated 800 line or through the secure online HCA support portal. The Outreach and Training Unit also supports the in-person fairs across the state. During open enrollment, benefits fairs are scheduled in-person events where an employee or retiree can learn about health plans and benefits. The dates, times, and locations are advertised in our October newsletters as well as on our HCA website. So next slide, please. The Customer Service and Outreach and Training Units work with other HCA divisions on open enrollment activities throughout the year. We prepare the Benefits 24/7 system and our Pay One system for open enrollment readiness to include plans that are available by county, premium amounts, messaging, et cetera. Last year, we conducted focus groups with benefit administrators from both SEB and PEB, who specifically reviewed the spousal attestation and dependent screens within Benefits 24/7 and the Open Enrollment Wizard. We received great feedback and we were able to implement changes to that wizard prior to open enrollment beginning. We also received some positive feedback from benefit administrators who participated, as well as a request to continue these types of focus groups throughout the year. So we are looking at additional opportunities to be able to do that this year. The Outreach and Training Unit secures vendors' locations and schedules for the benefits fairs. We offered a pre-open enrollment training for benefit administrators in October to prepare them for open enrollment, and we continue to work on the virtual benefits fairs. The virtual benefits fairs is an online website created with the same goal in mind as the in-person fairs. Some of the features are members can learn about their benefits from their home. It's available anytime, day or night, and can be accessed via a computer, smartphone, or tablet. Some carriers provide direct interactive webinars, pre-recorded webinars, or teleconferences to share plan-specific information. So next slide, please. some of the highlights. So I want to provide some of the highlights for this open enrollment. Open enrollment dates were October 27th through November 24th. From the first day of open enrollment through the last day of open enrollment, there were 55,881 SEB program members that logged into the Benefits 24/7 system. There was no downtime in Benefits 24/7. There were no SAW outages. There were no storms that impacted this year. So we closed open enrollment on time at 11:59 p.m. So paper forms were also available on our website so that members could choose to make changes online through their Benefits 24/7 account or on a paper form and turn it into their benefit administrator. The outreach and training team received 1,085 HCA support inquiries from SEB benefit administrators. Compared to last year, we had 1,574. But as a reminder, that was the first year we were using Benefits 24/7 for open enrollment. So we did see a slight increase last year than we did this year. So next slide, please. We continue to use member feedback to plan for the benefits fairs. We hosted 14 fairs across the state. Locations for the fairs were selected based on member enrollment. We also supported 4 fairs that were hosted by University of Washington. This year, we continue to offer the virtual benefits fairs, as I mentioned. There were 21,920 visits from SEB program members. Some of the most popular pages were from UMP, Premera, Delta Dental, MetLife Vision, and Davis Vision. And as I mentioned, the virtual benefits fairs are available 24/7, so it's definitely a popular option for folks who can't make it to an in-person fair. Next slide, please.
And I like to highlight where we've incorporated either benefits administrator feedback or member feedback. One specific piece of feedback that we took to heart this year was we didn't make a benefits fair that competed with trick or treat. So no benefits fair on October 31st. We definitely received that feedback that was hard to juxtapose those things and avoided things like Veterans Day holidays or other things that might be impacting. So we thought a little bit more carefully about the calendar as well.
Thanks, Dave. Okay, so on this slide, you can see the net changes for each plan. You can see the total enrollment by plan for 2025, which is a snapshot that's taken in October just before open enrollment begins. In the next column, you can see the final open enrollment results for each plan effective January 1st, 2026. And then the totals in red show an overall decrease in the plan enrollment from 2025, the snapshot taken in October, to 2026. And the last column is the percentage change. Next slide, please. This slide is a new one that we did this year. So I wanted to provide a roll-up of enrollment by carrier over the last few years. You can see in the total enrollment by carrier in 2023 through 2026. You can also see the change in overall enrollment for each carrier in the last column from 2023 to 2026. So for example, you can see Kaiser Permanente WA has an overall decrease since 2023 of 17,383, while Premera has an overall increase of 2,960.
I thought the board might appreciate seeing this level of detail about kind of net changes over a multi-year period because of the volatility that has existed in various premiums and wanting to kind of know kind of like beginning to end story. I do think it's important to note that if you look at 25 and 26 compared to 23 and 24, the trend year over year, it's starting to kind of level out. So that's something that I was particularly interested in with the premium changes that happened between 25 and 26 as to how much more net change would there be. There was obviously a large amount of switching that happened between 23 and 24, which was that first year where there were some really significant premium increases that the board struggled with. And just thought that it would be interesting to see kind of the trend overall, as also the more recent trend and see that, there's less significant switching happening in the more recent years, but big picture, there's still been a lot of change. I think it's also interesting to just see the natural growth of the entire population growing by 12,500 lives. Some of that is expansion of positions in different years in some school districts. It could also be more dependents being added on as people are changing or losing access to insurance in other areas. They may be being brought on as dependents here. So I just think the natural growth. Remember that although there is now statutory authority for other K-12 school entities to be able to join, like tribal schools or unions that represent school employees, we haven't had any actually join us yet under the SEB program. So that growth here isn't related, isn't coming from that. It's coming from current districts, ESDs, and charter schools.
On this slide, you can see a view of where subscribers started and where they switched to for 2026. For example, 368 moved from Primera Standard PPO to UMP Achieve 1. I lost my spot. And then we had 543 subscribers moved from UMP Achieve 2 to UMP Achieve 1. And then you see 2,348 that subscribers moved from UMP Puget Sound High Value that either selected to move to UMP Achieve 2 or were defaulted since that plan was no longer available in 2026. And then the same for UMP UW. There was 2,233 subscribers that either changed to UMP Achieve 2 or were defaulted based on the plan no longer being available.
And Alyssa, this chart just shows some of the larger volumes. I call this the tube chart, and she filters the chart so that you don't see very small numbers, or else you'd have like a big yarn ball on this page. And so just highlighting that there's a lot of more changes that are happening that you're seeing here. You're just seeing the macros, larger shifts.
Next slide, please. So on this slide, you can see specifically the folks who moved out of UMP Plus. So you can see 581 of the subscribers went from UMP Puget Sound High Value to UMP Achieve 1, and 1,499 went from UMP to UW to UMP Achieve 1, and then the same as the previous slide that I went over. So next slide, please. And finally, on this slide, you see a different view of movement based on the deductible being low, mid, or high. You can see from the chart that there were a total of 8,151 employees in a low deductible plan in 2025, compared to 6,769 for 2026. There were 3,425 employees in a mid-deductible plan in 25, and we see an increase to 4,923 for 2026. And then 2,470 employees were in a high deductible plan for 2025, and there was a slight decrease for 26 to 2,354. So we see a lot of people making decisions based on overall costs. So that is the end of my presentation. Are there any questions or anything else you wanted to add, Dave?
So I'm going to ask you the same question I asked yesterday, so hopefully it's not too much of a surprise. What are any lessons learned or things on your radar to improve for next year so far?
Yeah, actually, in the meeting yesterday that we had with some SEB benefit administrators, somebody mentioned something about an open enrollment guide for employees, and I thought that was a really interesting opportunity. So I have that on my list of things to look into. But the focus groups that we conducted with the benefit administrators, both in PEB and SEB, was really helpful for us to see the perspectives of not only the employees, but the benefit administrators who are helping those employees. So we are really looking forward to continuing some of those focus groups and looking at different areas of the system that we can make an improvements just for a better overall customer experience. So those are some of the big. And we also, I know I mentioned yesterday, we are working on some new reports that will hopefully help benefit administrators better serve their employees.
Oh, go ahead, Laura.
Sorry, were the focus groups only with benefit administrators, or were they with like a sample of employees too?
They were just benefit administrators. So we started small, really focusing on the folks who are supporting the employees. But definitely something we can be thinking about is how we can incorporate some employee feedback as well.
Yeah, I might think that might be helpful to actually get an employee's perspective. Benefit administrators use the system frequently, and so something that seems simple to them might not necessarily be simple to employees because they know how to navigate throughout benefits 24/7, just a little more. I would say I still didn't think that the spousal attestation was still quite intuitive. We had some employees who were used to doing it or thought they had to do it, and it wasn't something they had to do this year, and they were looking for it and couldn't find it because it wasn't asking them to do it. And so they were digging around trying to find it, thinking,
Generating more questions for the benefit administrator. Great. Yeah, thank you for that.
I just also wanted to add that I've been the director now for 9 open enrollments. And of the 9 open enrollments, this was easily the smoothest one that we have had. Now, that's not 9 for SEB. I think I can't do the math that fast. Was it 5 or 6 for SEB? But overall, this was by far easily the smoothest open enrollment. Not just because we started and ended on time, but we didn't have, weather events and other questions, and we didn't have a unexpected saw outage, which wasn't in the agency's control, or any other, those types of issues. But by all metrics, our call volumes were lower than they had been in previous years. Can they be lower? Yes, but they were trending in the right direction. Was the response time to benefits administrator tickets faster? Yes. Could it be even faster? Of course, but it was trending in the right direction. There was our document turnaround for retiree applications and COBRA applications during this period was completed by roughly the second week of December, and I don't remember that ever being the case before. And another just small indicator was there was no request from Alyssa for emergency overtime to get ahead on or catch up from behind on anything. So by all metrics, it was very easily the smoothest open enrollment that we've had. And so I just wanted to acknowledge that for the division team that puts together open enrollment and handles everything on a day-to-day basis, that it really was a good open enrollment. And we have a periodic, roughly bi-monthly benefits administrator meeting, one for PEB and one for SEB. And yesterday there was a similar sentiment that this was, of the SEB open enrollments, smoother than it's ever been. So just wanted to kind of convey that there's still plenty of improvement to move on from, but I was happy to see things head in a positive direction from all standpoints.
Any other questions from the board on this topic? Any virtually, Dina, online? Yeah. The bar is very high for the years that are in the future, Alyssa and team. I will say one marker for how well things are going is, and I welcome the public to openly write me. That's why public service exists in terms of help and support. But I also, too, got no outreach of requests in this time period, right, for any support or hangups in the process, which likely is the case in the times of the work that we do. So I see that, appreciate it, and thank you so much for the overview of the process. Okay, any other comments before we move to our next section? All right, we're ahead of time, which is great. We'll just continue on. We're going to move next into the legislative session and governor's proposed budget update. And with us, we have Cade Walker, our Policy, Rules, and Compliance Section Manager in the IRP Division. Just a moment for Cade. Cade was one of the first people to welcome me to Olympia as I was here for the first weekend, walking around downtown, and here comes running Cade to find me. Aren't you? I said,
in the picture.
I am that guy. I am that guy in the picture. So I appreciate Cade's warm welcome to Olympia. And Tanya Duell, our ERB finance manager in our financial services division. They're both going to give sort of a dual update, both on the legislative session so far and the governor's proposed supplemental budget. Obviously, maybe I'll just make some high-arching comments before I turn it over to them, just from a broad perspective, as you've been seeing from any of the news outlets that you pick up from your paper, the state fiscal picture in a precarious situation driven by a number of different factors, of which we talked about this morning. So I'm sure you will hear some of those components as we move forward through the presentation today, and I'm sure I'll comment as appropriate and available for both of this. And obviously, and Alice and I were talking about this last night, in the height of session here at the moment as an agency, it's about 50 days left for us as we move towards that March 12th deadline. And there is, while that is a shortened session, I think we would all agree there's just a ton of activity in the current present moment, both budgetary and policy related, just given sort of the substantial amount of changes and what folks are reconciling from both the interplay at the federal and the state level. So more to come on that, but Kate and Tanya, thank you so much for being here. Thanks for your leadership, and we'll turn to you.
Thank you, Chair and members of the board. Good to see you again. We'll start going through the rigmarole that we've done before. Now, this will be a little interesting this year because with the short session and the way the board meetings have kind of fell on the calendar, we're going to have one right now, which we're only about, as the chair said, about 10 days into session. And then by the time we get back to you, we'll be just at the cusp of session ending. So a lot will happen in between now and then. So what I will provide you updates wise today are going to be a little bit on the sparse side, and then we'll have a whole lot more to discuss on the policy side of things when we get towards the end of session. And then of course, my co-partner in crime here in the legislative session will have a lot more things to share with you regarding the budget, because where there's, that's going to be the big thing for this year. But that doesn't mean there's not going to be interesting policy things that they're working on and trying to put forward in due time for this year. So next slide, please. All right, so our little chart that we had that we break down, it's just as a reminder, we as ERB is part of the larger agency and responding to legislative requests and looking at things that are coming to from the legislature. We analyze things either in a capacity as a lead for the agency or as a support division for the agency. So if we're the lead division for the agency, then we are reviewing things not only for the impacts that it has to our programs that we have, but also looking at things and incorporating the feedback that we get from other divisions like the Medicaid program or Division of Behavioral Health and Recovery, or our clinical quality care transformation divisions, and we'll incorporate that into the overall analysis and provide that. But we would be assigned a lead because it's presumed that we would have the largest impacts to our programs based on that legislation. Otherwise, we're put as support, and oftentimes those pieces of support legislation might have an impact on our programs, might not have any impact on our programs, but we're just there to help support things, provide the feedback from our analysts on what the presumed impacts would be from our programs for the larger agency overall efforts. Then as we look, once we've had it assigned from our Legislative Affairs Analysis Division to us to be a support or the lead, then we'll break it up into whether it's a high priority or a low priority. And while this is a bit of an arbitrary standard, the real way for us to consider is the bill going to have some fiscal impacts to us? It's going to raise costs of our premiums. Is it going to cause us to have to spend money for a report? Is there going to be anything that requires us to change things up administratively? Is there going to be anything that requires us to hire any additional staff? Do we need to amend our rules or our policies? And if any of those things would result from the legislation passing, then we would assign it to be a high priority bill, which just means we're going to track a little bit more aggressively. We're going to follow a little bit more. If there's some things we need to have changed in it, we'll advise our agency leadership that maybe we want to ask for an amendment or have some testimony at one of the upcoming hearings. And so that's how we kind of break up the way we review bills. And so that's why we have it in this quadrant here. You see, as of last Friday, we had 39 bills that we reviewed. That number's up to more about 80 as of today. Because like I said, things are moving very quickly as we are just early in the session. And by the time I had to have my slides in, I was only able to track. I mean, those are numbers as of last Friday. So there's a lot of good fiscal notes that have been going through. I won't spend much time on that because that's Tanya's department. And it's just nice to note that. And I always like to call out her team doing a fantastic job. Those fiscal notes are always a tremendous amount of work that our team and her team has to put forward and get those out the door. Next slide, please. This is Dave's infamous funnel from, I don't know how many years ago he made this. I've never bothered to try and adjust any of the margins or anything on it either. So it just remains after well over a decade of it being in use. This is our how a bill becomes law funnel on bills that we track that are our lead bills that are high priority. There's actually about 6 more bills that would be in this right now. So you can see that we're early in session right now. Things haven't moved too far. But as a note, because this is your short session, for the legislative cycle, this means that the bills that were introduced last year during the long session that didn't pass the legislative cycle last year are reintroduced by rule. So everything that was introduced last year that didn't pass is automatically renewed or reintroduced. So those are live bills that can be moving at any time. Now, for the bills that I had talked about last year that passed and those that didn't pass, I also talked about, those are included the appendix at the end of my presentation. In fact, one of the bills that is in there I took a note on, I'll talk about in a second, has actually kind of been brought forward and is actively moving again. The bill regarding retiree supplemental bargaining, or bargaining for supplemental benefits for retirees. It's more of a PEB impact bill, but for our populations as well that end up retired, this would be something that would impact if it were to pass. But it was introduced last year, so that will be elevated to this part of the funnel by the time we get to the next presentation in a couple of months. Also, just of note here, you can see our cutoffs. Our first big cutoff on the left here is the policy cutoff on February 4th. So that's coming up rather quickly. And that's where bills that haven't made it past the policy cutoff are no longer going to be considered for this legislative cycle. Then that will be kind of a nice trimming of the things that we're tracking after the 4th. And then we move all through the rest of the cutoffs while bills are working their way on how they become a law. And then the last day of session is the 12th. So like I said, the next time I see you will be just a couple of days before the end of session, and we'll have a lot of updates on what policy things have made it forward so far. Next slide, please. Just as a quick update, last year we did have a couple pieces of agency request legislation that were passed by the legislature. This year we don't have any. That's not for any ideas. We've always got a bucket of ideas that we'd love to go and put forward and have passed. But given the budget and the time and the different factors of it, we thought it was best not to put any legislation forward. As mentioned, we have great ideas, timing and other aspects and funds, no mun, no fun when it comes to putting forward good ideas. So nothing from our division this year that needed to be corrected or other good ideas to put forward. But just as an update, and we'll have more information in a future presentation, that Senate Bill 5083 that did pass, we are working on implementing that currently. A lot of work's going into that and implementing the impact of that. And then we had Senate Bill 5478, which expanded the PEB board's offering authority to include the same type of optional benefits that the SEB board currently has. There was no requirement for anything to be passed, but as of right now, because the legislation now has been passed and signed into law, now both the PEB and SEB boards have identical benefit offering authority for optional benefit types like travel insurance or legal insurance, or there's a whole pet insurance. Don't forget pet insurance and things of that. So just an update on that. And we didn't have any legislative reports either, which I will admit makes me a little sad because I do love report writing. Don't ask why, it's just a thing I enjoy, but I'm going to scoot over a little this way. Reports are great. You learn a lot. Okay, so then we'll go on to what we're looking at so far. Current legislation, next slide, please. We're going to start with one that's going to would have a pretty significant impact on the SEB program. This is Senate Bill or House Bill 2160 with its companion 5883. This is regarding the eligibility for the SEB program for individuals who have worked at least 630 hours in the year prior. You may know that this is referred to as, and I'm sure Laura's aware, it's the 2-year look-back rule. That is not something that's codified in statute. It's a rule that was created after this board decided that they wanted to have a 2-year look-back rule for eligibility. So this is codifying the look-back rule, and instead of it being a 2-year look-back rule, they have instead it as a 1-year look-back rule. So if an employee in the SEB organization had worked 630 hours, were to work in the same type of positions in the subsequent year, they would be deemed eligible. They would be deemed eligible, even if there wasn't a presumption that they were going to work 630 hours. This is that rebut to the presumption of eligibility at the start of a school year that says if you would work 630 hours, it rebuts the presumption that the school district might make to say, well, we don't think you're going to work 630 hours this year. And they said, well, I did last year. I'm in the same position. Ergo, I'm eligible for benefits this year. I want to turn over to Dave. I know he's been working with a sponsor and WA on some other language there possibly.
Well, I just want to highlight that the 2-year look back rule, the way I describe it is the board had the authority originally they can't be more restrictive than the anticipated to work 630 hours that's in statute. That's the only eligibility that sits in statute today for SEB. But because the board can't be more restrictive, that means there can be modifications on the edge. And so the agency had advised the SEB board back before the program launched that part-time eligibility tends to be some of the diciest areas. It's where Katie Hatfield and the other AGs get involved sometimes, and historically had been the case for the PEB program. And so there were some analogies drawn from 2-year processes that exist for higher education faculty members, as well as seasonal workers in the PEB program, to create this idea of the way I describe it is the first year that an employer is making a hiring decision, they may not be fully aware of what their long-term needs are or how their workforce is changing. So you can be absolutely wrong the first year. The second year, if you're hiring somebody back to the same position, that's starting to be a pattern. By the third year, you've kind of got a trend. So then that's where this presumption of eligibility was generated through board policy, so that the districts or sub-organizations could rebut that if they have a specific articulable reason. But otherwise, it starts with a presumption of eligibility because 3 points starts to have a trend line. The bill that, as it's written right now, does a little more than just change the 2-year look back to the 1-year look back rule. It also would have school districts having to honor and recognize and count hours from other school districts for similar positions. So a substitute who is working some hours in the Tacoma Public School District and some hours in the University Place Public School District, those would be stacked together for purposes of looking at this look back for future benefits eligibility after 1 year. But in contrast to what happens today, multiple positions within a single school district wouldn't be able to be stacked. So right now we have a situation where sometimes, a bus driver might also serve as a food service worker in the middle of the day. And so those are two completely different types of positions within a single school district. They can stack today, but we believe that under the way the bill is written right now, that stacking of multiple positions within a district wouldn't count, but similar positions across multiple districts would count. So there's those couple of new features that are at least described in the bill. There was a lot of both bills in the House and Senate have had hearings at their respective fiscal committees. There were a lot of questions, especially on the House side. At least as of yesterday, the local impact or school district impact fiscal note that OSPI puts together was not released yet. So that's definitely an area of intense interest from some of the questions by committee members. Some school districts have highlighted and brought testimony forward to the fiscal committees about what they anticipate their local impacts would be. Some of them were a couple 100,000, some of them were in the low millions, a wide range of potential impacts, but I think everyone is eagerly awaiting the OSPI note. I do think it's important to highlight that for the agency's fiscal note, we end up saying that the bill looks indeterminate because we would assume that the revenue that's needed would be collected from SEB organizations for all eligible employees. So even though the revenue that is needed and would be expected would be higher, it would be fulfilled by the billing obligations to SEB organizations, and that there is not another change to the state fiscal model that's anticipated of the bill. So we basically describe that as an indeterminate. Is there anything you want to add, Tanya, on that?
No, I think it's indeterminate because we don't know how many people this would impact and how many new people would gain eligibility, but we just assume that we would receive the funding rate for each of those additional eligible members that come into the program. So.
And then I will say, based on the questions that have happened at committee, and the agency provides technical support on drafts of all kinds of ideas all of the time. There's, I think after OSPI's fiscal note comes out, we'll all get a better sense as to whether this topic has momentum this year or not. There's a lot of different ways that the bill could be written. We're providing lots of technical support on a host of ideas, and we'll see where it all lands. But it's definitely the area that is kind of the hottest topic at the moment. And it would be the first time that there's been additional eligibility rules or policies put into statute since the program's inception.
I'll just pause there, given the impacts it has to the program. See if there's any questions from the board on 2160, 5883.
I don't have any questions, but I will just speak from the business perspective of a school district to the other board members on how this impacts school districts. While, we're not against the idea of, increasing eligibility to those, that duly qualify under this thing, what is lacking is the funding piece. School districts are not funded to provide benefits to substitutes in the prototypical funding model that how we're funded. School district employees receive 12 sick days a year, and we receive 4 substitute funded days for certificated employees, and only those funded certificated employees. No funding for classified employees to have a substitute. So this, for our school district only, I did do the impact. It would increase our substitutes that are eligible for benefits from 15 currently, and we would have started the year with an additional 41 eligible employees. So it's about $630,000 to $650,000 in a school district with 1,500 regular employees or 11,000 students. So while we're not in support of this right now, if they were to provide some additional funding for this, we could get on board with it. But right now, the bill doesn't include any sort of funding. So that's why school districts right now are coming out as con against this bill, just because of the additional funding. It's basically an unfunded piece. So.
Thanks, Laura. Pam, and then I see Donna's hand raised online, but Pam first.
Well, and to follow up, you know, because like conceptually, we should want to do this. We should want everyone to have coverage. I mean, conceptually, but I'm wondering too, what was the increase in number for just your district? 41. That's an increase in workload then, which I'm going to guess you're not going to get any more time and staff for, you know, so yes, we conceptually want this, but I'm going to echo the concerns. But we need to think of, and I think reflecting back on what our panelists were saying, anytime we make a change or anytime we make a proposal, it impacts everything. So this sounds great. I want it. But, you know, thinking of the impact of workload on the impact on our employees, just putting that out there.
Thanks for your comments, Pam. Donna, online. You are still on mute, Donna.
I did one button and forgot the mute button.
Perfect. Now we can hear you. Yeah, go ahead.
Sorry about that. Yeah, as the representative for the classified staff that's here, which this is who it mostly impacts, the disruption that it causes for our like our bus drivers, because a lot of bus drivers start out as a sub first, and some sub bus drivers actually end up getting more hours than a regular bus driver. The disruption it causes to their medical benefits is pretty impactful, you know, and so you're talking about the staff in the office, but you're also talking about the staff that are supporting the teachers and the students in the fields too. So our unit is in favor of this. So
I should add, I dropped a breadcrumb about an hour ago and I forgot to pick it up. The concept of churn in the system and various types of insurance individuals have, that is something that has been a hallmark of the testimony of those who are advocating for the bill so far, is a substitute who gains hours or reaches 600. They're not anticipated to work, but they actually work 630 hours, and they reach that 630 hour threshold sometime in the spring, and they learn that they get benefits in April or May, but then by the time they enroll, their benefits end at the end of the school year in August. You start to stack that up about how hard it might be to get a PCP appointment in a 2 or 3 month period, when the example from Ian was 8 months for the PCP that he was seeking. And you start to see that, well, you know, they might have insurance, employer-sponsored subsidized insurance for a couple of months of the year, but when the school year starts, they're back to wherever they were, which might be Apple Health, it might be others now unsubsidized exchange coverage, it might be uninsured, and then that repeats itself where they maybe get back on SEB insurance sometime the following spring, and so they're experiencing lots of churn. And so that scenario is exactly one of the reasons that I think there's been advocacy to move the look back rule to 1 year. Now, I do want to highlight that we haven't brought something like this back to the SEB board because of the potential wider cost implications, and kind of encourage the board to not revisit the policy in the short term, because it really felt like something that was a bigger expansion than might that the legislature really should chime in on. And so I just wanted to highlight that as well.
Donna, you had your hand raised for an additional question. Then I think Allison. Donna, any more?
It wasn't an additional question, but it was regarding the disruption in service and resetting of deductibles, and again, making those appointments out ahead. So, but again, I think the bill needs to be worked on. But thank you for talking about it today.
Donna, thank you for your comments. Allison?
I think just playing off on this churn idea, I feel like your bus driver example is probably one of the types of employees that are going to feel the greatest impact of some of the tax credit repeal as well. And so it isn't as if they're balancing between their SEB insurance and Medicaid. They're likely in that I've got to go to the market, and where we've seen premiums go up by such a ginormous amount, many of the option is going to be not to have health insurance, because I still need to pay for my increased housing, my increased food costs, my increased living expenses in that way. So I just, I know we are in a fiscal crisis as a state, and I think you can't not reflect on what we heard around it's going to cost us all more over not even that long of a period of time.
Thanks, Allison. Any other comments, questions from the board? Yeah, Laura?
Sorry, one more comment. I think Donna's point about the bus drivers, that is a pretty typical scenario of what occurs. They reach eligibility and then they pop off benefits, which I understand the disruption. So that is the typical scenario. But what we also see is a large number of retirees that are coming back to work, and they end up working more than they probably planned, and they reach eligibility and they don't even want the benefits. We have to tell them they have to enroll, and they don't want the benefits. And so we end up having to pay for something they don't want. And school districts ultimately don't want to have to pay for someone that doesn't need the benefits. So I think there's some work to do as far as, right now there's no sort of opt-out kind of, you can waive benefits, but school districts are still on the hook. And honestly, some of the substitutes feel bad that we have to pay for something that they're not going to use and they don't want. So some work to do there. Also, the part about stacking between districts, I don't even know how that works with reporting hours. It does create the administrative burden on employers of just some additional data sharing, and who ultimately becomes the payer for someone that worked in two different districts. Who does the responsibility and the burden fall on? How are we, becomes a billing nightmare basically for that aspect. And then I know we're still waiting on OSPI's fiscal note. Not quite sure how they're seeking the total burden on all of the districts for the additional funding cost, but it's quite large.
I should highlight that the current systems for HCA don't have a way to help support tracking hours across districts, and our billing system from the 1950s, which we're going to talk about more later, 50 years old, 1970s, doesn't have split billing. We can only charge one employer per individual in the system. So we don't have a way to split bill. And in the higher education space, where there are faculty that work at multiple higher education institutions, right now what happens is the two higher education organizations collaborate, make a decision, and one of them pays it, and the other one either may reimburse them behind the scenes, or this time you picked up and next time I'm going to pick up, and they just kind of do a trade, and it's all in the background because our 1970 system can't support that at this time. So once we get to modernizing our accounting platform, we can be thinking about things like that, but that is not, unfortunately, something that we can help facilitate with our systems right now. So we've been highlighting some of that related to this burden that would happen across districts, especially cross-district stacking of hours.
Okay, cool discussion. Just one note, I think it's interesting. One note on our analyses that we perform as part of our responsibilities is just a general question. It kind of then narrows down here. When we're doing our analysis, I've got a team of about 35 staff within ERB that work on different analyses. And the thing I instruct them all the time is you need to you're reviewing this from a very neutral lens point. And the analysis are done is we're looking at this factual. We're here as we're supporting the policymaker, the decision makers on what they're doing. So we're reviewing it from what are these impacts that have our program, from the impacts of there's going to be that fiscal impact, there's going to be this logistics impact, there's going to be these individual, there's going to be the churn impacts, and all these impacts are there. And whether or not that is something they want to support or not, so we put as we have a position that we have. And if I see a position anything but neutral on almost anything, it's like, well, you better have a darn good reason why we have concerns about something, which is the only other option I like them to choose, because it's like support or not support. It's like, no, we maintain neutrality in what we're reviewing as our position as the executive branch. We're reviewing things from that neutral standpoint and trying to include as much information for the decision makers to make those decisions. And so I saw Dave taking a lot of notes, and I'm sure he'll relay a lot of the concerns and issues that were raised by the board to them. Just those would never find its way into our analysis. We use for internal purposes just to review those things and help inform our decision makers internally of what they need to do in communicating with the authorizing environment and with the legislative environment. So just a note on that.
And before you move on to the next bill, I want to highlight, I think there are some members of the public who raised their hands wanting to engage in the conversation. And if you weren't here at the beginning when Chair Moran highlighted how this all works, during the session throughout the day, we limit questions to the board members. And if you have questions, you can always send an email to the presenter. Their contact information is at the end of their current slide deck to get real-time questions, or you can bring up topics and any questions and thoughts you have to share during the public comment period at the end of the meeting. So just wanted to recognize that we see some of your hands, but the protocol we use is to reserve public comment for catch-all questions and information that people want to share from the general public. But you can also always write us anytime. And there's emails throughout the materials to send questions to the hopefully applicable person.
Thank you, Dave, for that point. And then I'll just note for the public too, want to engage in that period of time on our agenda will be around 1:55, just to give some people some sense of when that comment period will likely be. Okay, Kate and Tanya, back to you.
All right, I'm going to try and go quickly here through the next little things. So they're not nearly as fascinating as that bill is. So, I mean, interesting, but probably won't engage as much conversation. So 2106, I'm gonna see if I can do this in like 4 minutes. 2106 is going to require, it has some additional requirements on when carriers are negotiating, want to send some, what they call substantial term, so significant contract modifications, which are like downgrading the payment fees or changing the payment systems, and they require a 90-day notice for between the carriers and the providers, which would have some impacts on some of our population if they get to those contract requirements where they get to that 30 days and the contract hasn't been signed and they're sending out those notices. So just one of those things we keep an eye on to see what might happen with those notices. Then we have House Bill 2242 with its companion 5967, which is being led by our clinical quality and care transformation team. This is really think about the legislation that would be required for the multi-state compact regarding immunizations and vaccinations that has been created between the four West Coast states. This is working to codify a lot of those recommendations, or a lot of that authority to allow the Department of Health to enact those recommendations. Then we have House Bill 2145 and its companion 5981. This is about trying to preserve some of the savings from federal programs, the 340B drug pricing program. So it have hopefully preserve and retain some savings and cost measures for regarding prescriptions. House Bill 1566, some changes on the prior authorization determinations. Another one of those things that we watch administratively that would have impacts on our carriers and then our members who need to go through services that require prior authorization. A couple that are not on the list here that, because it came up this week, we have House Bill 2546 and its companion 6071 regarding timing for health carrier overpayments to be for mental health services and all this. Well, it changes it to all services to a 6-month clawback period, essentially from a 24-month clawback period. The revived piece of legislation 1069-5044 that is moving or has brought back up the supplemental retirement bargaining for optional benefits. This was introduced last year and it's been revived, and we're tracking to see what happens with it this year. There's 2487 5949, which is regarding insurer taxes, which I don't believe has health insurance on it, but maybe it did, which is probably why we're tracking it. The insurer taxes 2487 5949.
Really, I think a part of this is there are a lot of bills that we track because although they may not be written in a way that currently in their current form impacts the programs, if they are tweaked a little bit, they might be. And so we have a watch on a lot of different things that even though on their face they don't look like they hit the program, we want to make sure that we understand if they're amended to hit the program.
Last two, 2522 regarding preventative dental care, creating some additional requirements for preventive dental care and the number of visits. And then last 6183 regarding access and coverage for HIV antiviral drug coverages. So those are what we are currently following. There'll probably be a bunch more that we'll be tracking before the 4th of February, but I made it in under my 4 minutes, and I will turn it over to Tanya, unless there's any questions for me.
I've never heard Cade speak so fast, and he can moonlight by listing adverse reactions to medications at the end of a commercial.
Yeah.
We do that pretty well.
So you have it in you. You can do it.
Thanks, Cade.
Thanks, Cade. So good morning, Chair, members of the board. I feel like it has not been 6 months since we were last here. It has flown by. I know, I feel like we were just adopting premiums not that long ago. Okay, so I'm going to do a update on the governor's proposed budget. So as a reminder, whatever we talk about today is not set in stone. We still have to see, the House and the Senate proposed budgets with a final conference budget. So this is just, what's in the governor's budget. More to come. First, we're going to just talk about the timeline really quickly. So as a reminder, the biennial budget was set last legislative session. So we are only dealing with a supplemental budget, which is tweaks to the current funding that is set for the biennial budget. Typically, we try to reserve some of the bigger policy changes or the really big asks for those biennial decision packages. So in the long session, they can deal with some of the bigger items. Our short sessions here, we try to do things that need true up or some smaller items that could be more easily implemented. So back in the summer, we looked at, what were we going to submit in our decision packages? Decision packages are a request for funding. We did those in the summer, and then the Office of Financial Management works with us to answer questions, work through additional assumptions, and then the governor released his proposed budget in December. Now we are in session, so we're starting to work with legislative staff on answering additional questions, running alternative scenarios as they make their decisions for their respective budgets. Last day of session is supposed to be March 12th. Let's cross our fingers that we are done on time. And then most changes that come out of that budget will start July 1st. So any changes we talk about will largely be July 1st. We're expecting another revenue forecast on February 16th. So I don't anticipate we'll start seeing some of those additional proposed budgets until after that date, once they have the updated revenue forecast. So first up, we're just going to walk through some of our requested decision packages and kind of what happened with those. The first one on the list is something I bring to you guys every year, which is our third-party administrator, our TPA spending authority. This is just something you will see from me annually to true up with our enrollment in our self-insured products. So as a reminder, for our self-insured uniform medical plan, we pay Regents for our medical administration and MODA for our pharmacy administration. And then on our self-insured uniform dental plan, we pay Delta Dental for the administrative fees there. So as enrollment changes, like Alyssa walked through, we will true up with the spending for our administrators. What is unique this year is you will see included final amount TBD, and that is because I made the decision this year to submit what we call a placeholder. Placeholder means we want to be on record saying we think we will need some dollars, we just don't know yet how much. And that's because when I started doing the modeling this summer, we didn't need a significant change this year. Enrollment was fairly stable from the year before, but it was unsure what was going to happen with the UMP Plus closure this year. So I kind of wanted to wait and see how things shook out. So I will be updating those numbers for legislative decision makers here. The next item was a smaller decision package around benefits improvements. Typically, you see one of these from us almost every year, where we're taking ideas from the board, from public comment, from our carrier proposals on things we want to look at enhancing as in terms of our benefits. Because of the budget crisis that is happening, Ryan spoke to some of the issues our state is having right now financially, we really wanted to limit requests this year to things that were kind of absorbable within the current funding and didn't require a huge influx of funding to the program as far as benefits requests. So we did request funding for increasing the employer paid long-term disability, which, as you remember, last year we did, and we got a small increase for the SEBB program that went live this January. So we are currently at a $450 employer paid benefit starting this month. But in this decision package, we requested additional funding to $650. As well, this decision package also included the request to increase our life insurance benefits. So the employer paid life insurance from $35,000 to $40,000. And these are both separate, so decision makers can pick and choose. They don't have to fund the full decision package, but in the governor's proposed budget, neither of these items were included. Next up was our, I would say, largest of our requests, which Dave will talk about a bit more here, which was our PEB and SEB fully insured procurement decision package. You probably all remember at the very end of the last board season, we had a really lengthy conversation around what would it look like to procure additional medical carriers into the SEB program. And we did submit a decision package for a fully insured procurement. The funding included in that decision package was largely around some of the IT work that would be needed to stand up a fully insured procurement. I will note that in the governor's proposed budget, the name was changed from the fully insured procurement to a benefits 24/7 enrollment file functionality. And so the funding was actually increased slightly based on some conversations we had with OFM in the governor's budget or in the governor's office from what we requested at $1.7 million per program to 1.8. So it was funded with kind of a different theme to it a little bit. But this was funded at 1.8 million per program. So 1.8 for PEB, 1.8 for SEB for 3 years, starting next fiscal year. Really with the emphasis being on some of that advancing of the IT infrastructure. Dave, I think you probably want to talk a bit more about that.
Yeah, I'll talk a little bit about it here. And then at the end of the day, after we've had some presentations about benefits 24/7 and some project work that would stem from this decision package, I'll talk a bit more about kind of the position for a future fully insured procurement. I think it's important to highlight that the request that was originally put, well, let me step back. When we left board season, I said one of the next indicators that is important for this journey of having authority to move forward with a fully insured procurement is to identify resources that are needed and tee up a decision package. So check, the agency did do that work and we put it forward, and now decisions have to be made about that. The shift in name to the decision package that we put forward was really elevating and highlighting the criticality of the IT infrastructure, which was inherent to the DP that we had put forward. So it was kind of a rebrand of the DP to kind of, again, emphasize that IT infrastructure. And really what was a determining factor as conversations went on around this decision package was that there are key things that really should be shored up on our IT system before we have the potential for additional carriers and additional plans and hundreds of thousands of people making changes that then have to have data flow through our systems. And there are things that should be better about that system. I don't think that's a secret to anyone. We've been talking about data sync issues for at least a year and a half now. And there are certainly some key aspects to the system that can be revamped of what's existing there today and moving some functionality from our 1970 system to our 2020 system. And being able to make those improvements is really seen as critical before we would be on a path to implement effectively the results of a fully insured procurement. So that's really what the support was from the governor's office in the budget. And I think it's really important that we are seeing, and even in these times, this potential investment coming from the governor's office in our IT systems. Aging IT systems is a cliche across the country for state government, but the system that we use that is the background for accounting and eligibility files really is it's quite old. I like to say and remind people our system is older than Garfield the cat, being a comic strip. It's older than the first Star Wars movie. It dates back and predates the Ford administration. And my last two for timing is it predates the personal computer being sold on to individual consumers. And it's older than not only, I gotta get this one right. Meryl Streep wasn't even nominated for an acting accolade, let alone won any. So our system for accounting is really quite dated. And so being able to finally make some additional investments is really key. And I'm glad that the governor's office and OFM saw that and supported it as critical to being able to make broader policy decisions, not today, but soon for other aspects of the program. So we'll talk more about IT and this decision package of fully insured procurement. That was a snack, and we'll get into the meal later.
I'm just giggling because we used to have a horse and buggy
Yeah.
on our little infographic about Pay One, and I took offense because Dave and I are not much far off in age from Pay One and horse and buggy. All right. So next, we're going to talk about a couple of additional things that were in the governor's budget, but I want to do a pit stop really quick on kind of where we landed last year in terms of budget deficit. So we had quite a few conversations last year around how we were contributing as the SEB program to the state's budget deficit. And we talked a lot about how the PEB and SEB programs are not directly general fund accounts, but we kind of get passed through general fund dollars. So the SEB dollars that come into the program are about 82% general fund that come to us. But once it gets to us, we are not considered general fund here at HCA for PEB and SEB. So when they're looking at solving, the general fund deficit, it's always a question whether the PEB and SEB accounts are part of that calculus or not. So last December, Governor Inslee actually put on a freeze for non-essential spending, and we had to put a freeze immediately on hiring, non-essential service contracts, and travel. And that was done in late December last year. Then when Governor Ferguson took office, he further directed agencies to look at additional cost savings options. And because of that dynamic with us not being directly general fund, we were still asked to submit proposals for budget reduction options to help contribute to the deficit, because while we're not directly general fund, some of the dollars that flow from the employers to us are general fund. We did a presentation here at the board walking through the various options that we included on our list. And at the end of the day, in the last conference budget, things like reducing our premium stabilization reserves were included, cashing out some of our employer paid long-term disability reserves were included, the closure of the UMP Plus plans, as well as ending the wellness incentive were all included as things that the SEB and PEP programs did. In addition to that, we were also directed to take a 6% administrative cut to our admin budget. So we have multiple admin budgets, but the one really that pays for our salaries, building leases, things like that, we did have to take a 6% cut on. Those things we're doing right now, but on top of that, in this supplemental budget, there were some additional directives as part of the budget. So the first one is proposed agency level administrative reductions further tied to additional travel, goods, and services. I will note, though, that these were specifically tied to general fund and did not impact the PEB and SEB funds in the supplemental budget. As well as in the back of the budget, and we say the back of the budget because in the back is where they do a lot of fund transfers and some unique items, there was an additional reduction of about $11.7 million for the state to reduce WMS and EMS positions, salaries. There were no specifics to how this would be operationalized. I do believe, based on conversations, that was based on a general fund calculation. So the general funds that pay for these WMS and EMS positions, but nothing has been, said as, HCA will cut this much from these types of positions. If these both stay through the final conference budget without additional directive from legislators in the budget, OFM would have to figure out how to operationalize these at the end of the day. I'm just bringing these up because while they don't directly impact PEB and SEB at this point, I don't think it's out of the realm of possibility that the PEB and SEB programs could be hit with further reductions. Things from our prior reduction list could be revived, or these could be asked to be included for the PEB and SEB accounts also. So more to come on that. Again, we still have a ways to go with the House and Senate budgets, and I'll bring those back at the next board meeting, what comes out of those budgets.
Can I just make sure I understood what you're saying? So those Washington Management Services, Executive Management Services inside the HCA budget, there are line items described that way. And you're saying that across the whole, there would be an $11 million.
So for the first one, there is the proposed agency level administrative reductions, the first bullet, there is a line item in the HCA budget for those reductions, but not for the PEB and SEB funds.
Okay.
So there could be some trickle down impacts to PEB and SEB, but the way it's written now, it's only the general fund cuts.
Got it.
The second bullet, there is no line item in any agency budget. It's one big bucket in the back of the budget that directs OFM to find that $11.7 million. There's no specifics around if it's cutting positions, if everybody's taking a small salary cut,
Got it.
there is no direction in the budget.
And they
So
could decide
Ledge could
this
decide.
agency is going to take a bigger hit than this agency because
Absolutely.
this is not a priority. Got it.
Yes, yes.
Got it.
So
Okay,
if Ledge
thank you.
doesn't describe it further in the budget, OFM would have to do that after.
Well, that's an
after.
interesting predicament.
Yes. But I will say there are various funding sources throughout the agency. You know, Dave and I specifically, you know, we support the PEB and SEB programs solely. So our funds are PEB and SEB, you know, where maybe others are split because they support federal dollars also. Yeah. Yeah.
Yeah.
Yeah.
Right. And for everyone who might not be as, you're probably more all familiar with the classification schemes in K-12 than you are with state agencies. We have three main classifications: WGS, General Services; WMS, Management Services; and EMS, Executive Management Services. A rough way to think of it is a lot of public-facing positions that support consumers or customers or clients are WGS. A lot more of kind of managing of contracts, for example. Everybody that has ever presented to you about a contract that we see, or is managing large teams, or has more autonomy and decision-making authority might fall into the management, general WMS management series, and then executive management tend to be the senior leaders of agencies.
So more to come. The next one is the updated funding rates. So just as a reminder, the funding rate is paid per benefits eligible employee. And this kind of ties into some of Laura's comments about, you know, additional subs. This is the amount that we expect to be remitted for every benefits eligible employee. And this amount covers things like the average medical cost per account, dental, vision, life, LTD, as well as reserves. And subsidies.
Medicare.
Yep, subsidies for Medicare. So on the SEB side, we have about $75-ish of this funding rate gets transferred per employee from the SEB program over to the PEB program monthly to cover the retirees who are housed in the PEB program. And when we're working on the modeling for this every quarter, we're delivering updated models to the legislative staff. Every quarter, things can change quarter to quarter, and they can change sometimes fairly large. It's not unnormal to see a $40 million swing quarter to quarter with the large dollars that the SEB program spends every year. So all of that to say, when we were sitting here last year, we were delivering the model to the ledge staff that informed the 2-year biennial funding rates. So for school year 26 and school year 27, that was done over a year ago. And we're trying to predict what's going to happen in school year 27. So we always expect that year 2 during the supplemental year will change because we get just a year closer to that funding rate. We know what has happened with rates from last year, because they set the funding rate before you guys adopt premiums. So that's done prospectively. So we catch up with what actually happened to procurement. We make updates to trends for both medical and pharmacy. So as drugs, you know, are making shifts to biosimilars and have big impacts on our trends, we're updating those. We're capturing the updated claims experience from the past year, as well as open enrollment switching, additional people waiving, adding dependents to the program. All of those things kind of flow through to this funding rate. But one of the biggest things that does happen is that now the school year 27 funding rate you can see is 1361. And that's going to include changes from not only what's happening right now, but what happened in fiscal year 25. Because the school year 26, 1307 has been locked in. So we have to catch up with changes from fiscal year 25, changes in 26, and predicted changes for 27, all in that funding rate. So that's why that can swing. We're catching up with surplus that has maybe accrued or a deficit that is accrued from a prior period. So when we see a funding rate change, in this case, it was 1341 in the enacted budget. It's increasing to 1361. That is a combination of all of those things. If it were the opposite and we were seeing a decrease, it's not necessarily a signal that benefits are being reduced, coverages, you know, are being eliminated. It's just that fluctuation in, you know, projecting a cost multiple years in advance and things getting closer to the actual period for projections. again, I will update ledge staff here in the next couple weeks with an updated model. So they will have another quarter of experience to use to inform their budget. They might not land where the governor's budget did, but it's well within the legislative authority to set the funding rate lower than we recommend. And that's where then the next year they would catch up with that if they did underfund it. Dave always likes to say there's no magic number, and that's true, because we do spend so much, and we can land at the end of the year in a deficit, or we can end in a surplus. We have various reserves. For us, a few dollars difference from what we recommend is never, too concerning for us. That is my last slide. Again, all of this is just the governor's proposed budget, which is a great signal to kind of where things are going, but still a lot of changes could happen between now and the final conference budget. Questions?
I think the only piece I want to clarify for everyone, Tanya, you listed off the things that were adjusted or changed last year. And just want to make sure everyone knows that, yes, the Smart Health incentive is set to retire. That is something that has a long implementation road. And just a reminder that the retirement of that incentive doesn't actually go into place until
Last incentive will be paid on January 1st, 2020. Well, January 2028.
Yeah, so that's the other pieces were all implemented. The retirement of Smart Health has a longer on-ramp because the current collective bargaining agreement includes the value of the incentive through the plan year 2027.
What you earn in 27 will be paid in January 28, and the portal will stop January 2028, and that will be the last incentive paid.
So just one reminder about the implementation of that piece versus the rest that Tanya described that already are in place now.
Okay, well, we'll be back in a couple months, and
Questions, comments, thoughts, anything?
Thanks out.
I'll just say on the budget piece, I think, as a leadership team, we've really challenged the agency in terms of identifying 3 areas of focus for us moving forward of how we sort of weather the next few years. And that comes down to sort of 3 areas of, are we responsive to the needs of Washingtonians, just in what you heard on the panel, all of those particular things that the state is looking at in terms of what people will need. 2, how are we always centering closing health disparities and gaps and advancing health equity. And then 3, which is why I bring it up, is strengthening agency operations. And that's both inclusive of people, processes, and systems. And so back to Tanya's and Dave's review, and Dave will go into more details on sort of the support that's within the budget that providing us with the IT infrastructure and platform that we need. That is totally critical and huge for us as our underlying plumbing of our systems to be able to serve people in a better way. And it does matter whether you make that investment now or later. So we're incredibly, at the authority, grateful for that. And that's certainly in alignment with some of the work that we want to do to try to shore up our systems so we can better meet the needs of folks. So we welcome that investment and sort of the reconfiguration of that opportunity. I wouldn't even say it's reconfiguration just a name, but the content of what we were asking for that to be of success to move forward in the future included those particular elements. So just wanted to make that known. Okay. Tanya, thanks for your leadership. I am grateful for you and your expertise. So we are, I think, ahead of schedule, which is great. So why don't we, I think we had, is lunch here? Lunch is here. So why don't we reconvene here at 12:15 for our working lunch, so that honors our about 15-minute break. It'll give us a little bit longer. Why don't we convene at 12:15 and we'll jump into the next portion of our agenda for working lunch. Fantastic. Okay, we're going to enjoy lunch while we talk about contracts and benefit planning cycles. I can't imagine a better lunch and learn. So John, we'll turn it back to you to talk us through that. And for the board, both virtually and in the room, that's tab 6 for your slides and appendices.
Thank you again. I'll try to keep this low key and help with aid your digestion rather than conflict with it. So for most of you, you've probably seen and heard this presentation before. I just want to give a brief overview and kind of put it in the context of this year of the contracts renewal cycle and the benefit planning cycle. They're related, but we run them very separately, and they have some similarities and one in particular that's worth noting difference. So if we can go to the next slide, please. Okay, so those that impact the influencers, if you will, of benefit designs and plans that we offer, they're myriad. These are just some of the really notable ones, right? Starting with the board, the executive branch, governor's office, ourselves, the legislature. You again notice that it's a unidirectional, typically from the federal government, where there might be a mandate or a requirement that we're working to be in compliance with. And then, of course, members and our labor stakeholders, all providing inputs about what sorts of things would be valuable and of interest. All of that is kind of the one ring that rules them all, if you will, is the financing, right? We have to have the funds to be able to offer the benefits that are desired. So there's a tension there, and it's a healthy one typically. But as we heard earlier today, we're in a pretty tight situation right now, which is influencing what we'll be doing in both of the contract renewals and the benefit planning cycle. So I put in the charts that show the cycles, the things in the appendix, the things that I would call out for board members on those slides. Number one is that they're both from beginning to end 18 to 24 month cycles. The moment that we have the idea that we want to cover something to the moment we can actually include it in a new plan or an existing plan is about 18 to 24 months. And a lot of that is tied to the review and the budgeting process that has to happen and then incorporating it for open enrollments. The one thing that's different, and again, we're not going to go through those slides here, so I'll just call it out for you, is that while they're typically 18 to 24 months into the future, they're offset by a year. So what we're doing in the contract renewal cycle is 1 year earlier than what we do in the benefit planning design benefit planning cycle. And we'll get into a couple of reasons for that in the next two slides. But any questions on the influencers or the design? As I said, this is probably old hat for most of you, what the cycles look like, but if no questions there, I'll highlight some of the similarities and differences. Okay, next slide, please. So the contracts renewal cycle, key thing, it typically applies to existing relationships. This is where we're talking with our existing vendors and payer partners to hear what they're seeing in their larger business models and what kinds of ideas they might have that we should be considering. We're going to run that process as normal. We'll reach out. We've already issued the request for information to them. So it's in the process. And as they respond to us, that sort of becomes the document that will help us build the rate proposals that we'll all be looking at here in this forum later in the year. We'll also be communicating the fiscal environment that we're in right now and trying to manage expectations, because as you can imagine, most of the payer partners are anxious to tell us about everything they've discovered that is the best thing since sliced bread and wanting us to adopt it or consider it. And to the extent that we need funding to do that, it's going to be a pretty challenging environment to have those conversations this year. So we'll manage those expectations, but we'll still want to be aware of what they're seeing in the rest of their books of business. And be able to assess, is that something, an opportunity that we should be looking at for the future moving forward as things start to hopefully ease in the near future or the forecastable future, put it that way. So existing relationships, current vendors and partners, it's more of an expansion or new ideas that they might bring to us that we'd be reviewing. And then if we go to the next slide, which is the benefit planning cycle, this is one where we're reaching out typically, maybe with an existing partner, but it's a really new idea. It's something that we haven't contemplated before. They may not have contemplated before, and we're looking for partners to be able to help us offer something. We're using a streamlined process similar to what we did last year, where we're not looking for the big, grandiose, really expensive ideas. We're looking for things that we can do and evaluate for considerably less impact financially, and it might make a significant positive impact for members. We're continuing to scan the industry and the markets. That's what one of my teams does routinely, where we're looking for those ideas and then trying to run with them or develop them further, that specifically for the state of Washington and for, school employees. It might have a notable impact or appeal. And then we'll still be reviewing, we started this last year, benefit additions that we've made over the last few years, where we were seeing lower than expected utilization. And we're looking for a couple of different things there. Number one is it that it didn't have the same value that we thought it would from a member perspective? And is there something we should do to address that? And maybe a change in the way it's designed? Or is it a matter of, we just didn't do enough educating with members? They may not be aware that it's there and available to them. And so there's an opportunity to increase the awareness and the engagement on it. So, but we're not doing the big, asking you for your ideas, what you're hearing right now. You're always welcome to share those with myself or my team or with Dave. Always happy to hear those, and we'll continue to look at those and evaluate them. But just being, we don't want to be tone deaf to the fiscal environment we're in. It's unlikely we're going to be able to get funding for anything truly large, but that doesn't mean we stop the work, right? So feel free to, and if you have any today, I'd be happy to hear about them. In fact, I'll make the ask. If there is anything that you're hearing from constituents, would love to know about it, so that we can at least have it in the review that we're doing.
I'll just also add, Tanya talked about the decision package that the agency put forward that had relatively minor modifications that could have been made to the employer paid LTD and life insurance benefits. And when we say relatively minor impacts, would not even adjust the funding rate by $1. So a lot of things in the modeling, a dollar threshold, or really it's 50 cents, because once you get to 51 cents, it rounds up and counts as $1. We were really trying to target things that literally would not have to have the funding rate adjusted by even $1 or round by $1. And each of those two that we had put forward met that criteria. Combined, they did not. And so with that not being picked up, that's, I think, a signal to be very even more diligent and careful about potential proposals on things of expansion. And we heard in the panel in the morning, that in a relationship between cuts and Medicaid and how it impacts all of us. And, there's a much bigger state piece here and state dynamic to think about. So that's really, to us, an important tea leaf to kind of frame the conversation the way John was, that it'll be a much different kind of analysis that we go forward with in the next year or two, because of that dynamic. Now, of course, the legislature does something, because the legislature can pick up any decision package. They're all public. They can do whatever. They can do something completely different. But we wouldn't anticipate that if even something that doesn't adjust the funding rate by $0 was picked up, then something that certainly cost lots of money would have an even harder hill to climb. So we thought, normally we don't bring to you the outcomes of all decision packages. We focus on what was picked up, but we thought that the context of something not even adjusting the funding rate by $1 was important to know as we start to typically talk about a benefits enhancement conversation. It really kind of, unfortunately, I try to be optimistic, but there's some cold water there. I see anxious microphones. Laura.
I just have a general question. If the emails that we get to that general board email account, if those are incorporated, because sometimes those come from members directly, is that on us to communicate back like, oh, or do you guys already look at those?
So the emails that are directed to the board email, the agency will take kind of the administrative function of managing those. That we package that information to you kind of on a month by month basis, especially as we're in board season, that here's the raw email that came in, and then here's a brief summary of how it was addressed. So you never have to feel obligated to respond on an individual basis. You will know that the agency will be going through those things. If you're unsure if the agency got the email, you can always forward it to me and Jessica, and we'll make sure that it's incorporated. There's a couple of entry doors, if you will, and then it all funnels to the same place. Do keep in mind that if you decide to respond on an individual basis, you have created a public record that you would need to make sure that you give to the agency so that we can be appropriately responsive to public records request. That's just a reminder about that, because I saw Katie perk up. So I just stole her thunder there. But we will always respond to those. And as members send something in that is a benefits idea, that is another arrow to the piggy bank on the first of John's slide is like an input method for potential changes.
And we have various avenues for those to get to us, right? Whether it's through customer service or a direct email, whether it's to one of us who's presented and someone's giving feedback, or to customer service as they're hearing things. So, yeah.
I do think it's going to be important. I'm really saying this for folks behind me that work on a lot of the responses to those correspondence that, especially with the budget dynamic the state's in, that we should think a little bit more about some additional language we should put into manage expectations of the our general members who might be emailing us about specific benefits that we know are particularly costly to think a little bit about how to manage their expectations in our current budget environment. And so we should work on that team.
And just to put a finer point on that, and Dave, I appreciate you bringing that up. The ones that we would expect in this environment to see is if there's an individual mandate from the legislature. Dave called this out, but I want to put a finer point on it, that that's really the only major expansions I would expect in the current environment.
So as an illustrative example, if the legislature passed a fertility bill and mandated benefit coverage in PEB and SEB as part of that, that would be implemented. You're not going to see the agency put forward a decision package on that at this time because the legislature is kind of aware of it. It's been very talked about. And if there's going to be funding added, that would be part of a bigger discussion. Pam.
Well, you stole part of my thunder because I happen to know I have some members watching this today, that this is not the year to bring up big ideas that are expensive. You know, the state is going through a budget crisis, or individual districts are going through a budget crisis. This is not the year, to my friends who are listening, to ask about 100% dental. I'll say it every year because it's my favorite topic, but this is not the year. I think we're really we need to survive. We need to get by. We need to make sure we have healthcare, period. And unless the legislature does something, fingers crossed, we're not really asking for anything this year, but just want to go on the record. This is not the year, even I'll bring it up.
Thank you, Pam. Anyone else have questions, comments? We have a perennial list that we're aware of. More employer subsidized dental is it? Increasing the LTD and life insurance benefits are on that list. Fertility benefits are on that list. Vision coverage is on that list. There's the weight loss medications is a very complicated topic, which also has some legislative prohibitions at the exact moment. And that one is squarely a legislative decision at this exact moment. But yes, that's another example. There's a perennial list always kind of being perused. And then I did want to highlight when John talked about doing continuing industry scans, that includes looking at our local market in our state of other employers, both private and public, and making sure that we're aware of kind of the competing benefits that the same workforce might be looking for. So we do that as part of the industry scan.
It's a great call out. Thank you.
I have a quick question on the weight loss medication. You're saying if the legislature directed that was a coverable benefit, it would just be absorbed in. And it's a hot topic, but Kate didn't report on any legislation that would even be contemplating that. I'm just curious if you're still expecting that, or it is just a complicated topic.
It's a really complicated topic for sure. There are a couple of ways for the legislature to discuss obesity or weight loss medications. One is they could pass a benefits bill that is in like Title 48, Chapter 43 for commercial insurance, and then expressly apply that to PEB/SEB commercial plans as well, including UMP. Or right now, there is restrictive language in the budget that says the funding rate does not include the ability to cover these medicines unless there's a specific appropriation, but don't change anything about coverage for these drugs for like FDA circumstances like diabetes. So there's not only is there's a handcuff, if you will, in budget language, and there's not proactive legislation at the moment. They could, in theory, a path forward could be to release that language in the budget and then say, actually, for PEB and SEB, the funding rate that the number that we put that's not magical in here includes coverage for X, Y, and Z. That's actually a lot of times how benefit changes happen for PEB and SEB that are not overall market mandate bills, they will say, and I'm trying to think of the last example. Oh, the example of moving LTD employer from $400 to $450 in benefits in the operating budget that was passed last year. That's how it was done. In the back of the budget in section 9, 10, and 11, I think was PEB and SEB at those years. It says the following funding rate includes the ability to implement, and said as of January 1st, 2027, employer paid benefit of $450. So they can fund a benefit change in that budget without passing a bill. Or they can pass a bill and then also fund it. Either way, there's handcuffs right now, and doesn't seem to be any active discussion on changing any of it. And as a reminder, there's pending litigation on that for multiple carriers, including the Uniform Medical Plan right now. So there's lots of discussion on that topic everywhere. Any other questions?
Yeah. Well, as always, I thank you. Feel free to reach out at any time. Don't expect that anything would happen immediately, but we'd still like to know any ideas, things that are innovative or you're hearing about that we should put on the list and pay attention to over time. Thank you all.
Great. Thank you, John. We are moving right along on schedule, doing well on that. And I am pleased, we talked a little bit about benefits 24/7 and how that interplayed into the governor's supplemental budget on the IT improvements. And I think Travis Sherry, who is our newly appointed Chief Information Officer for the authority, and Jean are here to give us an update on the benefits 24/7 application. I just want to note and welcome Travis, who has served as Deputy CIO for HCA for, I think, 6 years, and has recently been appointed as CIO for our organization in January. I think one thing is clear, and I think you'll see it from the presentation of SEBB specifically, having a ton of confidence in Travis's abilities to continue to move long-standing information technology improvements and upgrades forward. And we are just grateful to have, Travis, your leadership here at the authority. So thank you.
Thank you, Brian.
Good afternoon, Chair Moran and members of the board. I'm Jean Bowie. I'm the SEBB Deputy Director. And Travis and I are here today to share some updates on what we have been doing to continue the strategic modernization of benefits administration through benefits 24/7. There have been a series of activities since the last board season and that we want to share and that are aimed at improving the system stability, functionality, and user experience for our employees and retirees. During today's presentation, we'll present some leadership and structure changes, provide some more information on the session priorities that Dave and Tanya shared, and regarding the resource enhancements and future planning critical to achieving these goals. Next slide.
Good afternoon, Ryan, Dave, and SEB board members. It's my pleasure being here today to present. My name is Travis Cherry. As Ryan has stated, I am the new Chief Information Officer for the Healthcare Authority. Prior to my role being appointed as the Chief Information Officer, I was the Deputy Chief Information Officer since July of 2019. Prior to arriving and onboarding within the Healthcare Authority, I served 34 years with the Department of Defense under the United States Army. I spent my entire career in the military in the IT field, and I have a very robust IT background. So I want to say thank you, and I'm looking forward to our discussion.
And as Ryan mentioned, we are very excited to have Travis in this leadership role. He was on board with us when we were implementing SEB, and so is pretty familiar with our business and with the IT challenges that we have right now. Next slide, please. So a lot of work has been done within the structure of the resources of the Benefits 24/7 team. Specifically, the team now, the entire team fits within the reporting structure of the newly hired IT senior lead. During the 2025 session, we received funding for that lead position as well as 5 others. All of those positions have been hired with the 2 new developers both starting on February 2nd. And so a lot of staff changes and help that are coming to the existing team. In addition to those positions, we were able to rehire a long-term pay one expert on a part-time basis to help with some of the transitions that Travis is going to be outlining. So that was a really big improvement with that team to have his expertise.
I'll just add that individual is somebody who was part of the original Pay One team, so has a lot of experience with our particular systems and jumped right back into things, and it was kind of amazing how quickly he could remember specific things that had happened decades ago. And on the PEB side of the house, some of the benefits administrators, other agencies were very familiar with him, and it provided some additional calming relief on how the agency was going to be able to move forward. Not as familiar a name for our SEB BAs, but on the PEB side, a welcome relief for some of our longstanding partners that, like I said, instantly got a lot of calmed nerves knowing that Romeo, is his name, was back at part-time to be able to help with some of this work.
And additionally, he was here when we first implemented the 834 eligibility file. So this next phase of eligibility file activity, it's just very kind of fitting that he's here for that. Next slide, please. So as Dave and Tanya mentioned, our funding requests pertain to some improvements to identify and address the system architecture and database challenges that have contributed to some of the enrollment issues that we've had. Additionally, the establishment of an application program interface, otherwise known as an API, for larger employers. And as I mentioned, building the capability to produce that 834 eligibility file. It's currently produced out of Pay One, and we're working to move that into being produced out of Benefits 24/7. And then additionally, the preparation for the upcoming Secure Access Washington migration to a new security solution. And the goal is that all of these activities could be completed before any other major system changes were undertaken.
Sure. I spend most of my day thinking about the Medicaid space. We're often talking about eligibility systems. Is it all the same system, or these are disparate system? Okay.
Yep.
Just because people in the public might not know which way yes meant, is they are different systems for Medicaid and for PEB and SEB. And if you think about it, the agency joining of the historic PEB and SEB programs and Medicaid was in 2012, 2013, 2011. And Pay One was created in the 70s and didn't have any envision with Medicaid. So an easy way to remember that they are completely separate is they were born from originally 2 different agencies.
Yeah, and in fact, the Medicaid eligibility side, sort of it's a triad amongst how that eligibility behemoth works. I call it sort of the front door of the exchange, obviously, and then the work that we connect with HCA and responsibilities that we have in that process and with DSHS. So it's a sort of a triad amongst the 3 for Medicaid.
Okay, next slide, please.
with every goal, we must have a strategic priority. So the next couple of slides, I'm going to outline a couple of strategic priorities that Dave, Gene, and I have been working on. First and foremost, we must stabilize the system. To ensure the system operates smoothly and reliably, we are in the process of identifying and resolving synchronization errors, redesigning modules that are prone to errors, and strengthening the overall system architecture. The system stabilization is obviously our number one priority for the current time, because we have to stabilize the system in order to achieve our other goals from an architecture platform. And another goal that we have set for ourselves is the application program interface known as APIs, for which Gene had discussed earlier. For those that not really sure what an API is, for example, it's basically we're going to develop an API that will enable seamless integration to large organizations such as UW and Wazoo as an example, significantly reducing the need for manual workarounds. An API serves as a common language when there's different software systems communicating with each other, to communicate efficiently without having to understand the complexity of each other's design, right? So I'm sure you're probably aware that there are a couple of workarounds. We're having to, move some things around because stabilization is not quite there, but we have identified some areas, and that is obviously our utmost priority is to stabilize the environment so we can continue on with the enhancements.
On APIs, I'll just add, University of Washington, WSU are obviously not SEB employers. They are part of the PEB population. And those two employers use Workday to manage their large employee populations enrollment changes. And then they need to get that data to the healthcare authority for our systems to be able to flow over into the 834 files, for example, and our accounting and billing practices. So the focus is on kind of APIs for employers who use a different enrollment platform. And right now, the only two that well, that's not true. The two largest are UW and WSU. We have a variety of employer groups. Those are the local governmental entities that contract with the PEB program that also have used Workday or another enrollment platform. And they have been asking about how they could eventually use APIs as well. We've also had some of the larger school districts who would love to have better data interfaces with us. And so this is the stage we're starting with, because we do have those two large employers in PEB where data flows differently. In the instance of UW, the data actually kind of flows backwards in our system is how I think of it. And for WSU, they literally manually key into benefits 24/7 everything that was electronically put into Workday by their employees. And so we want to have that not be the future state. So those are kind of the priorities. To create an API, we want to do it in a standardized fashion so that it can be replicated with others, like school districts, like large counties. But we're starting with kind of the more draconian situations that exist right now that just happen to be in the PEB program. I also want to say that for stabilization, you've heard us talk about stabilization and syncing a lot. One of the things that I think is different now than prior conversations and last year is the team is really going back to the ground floor of the actual architecture of the various coding buckets that are used in the database that then syncs those together to produce a file that is about Pam and all of her things, or Laura and all of her things, and really going back and saying, well, some of the way that database and architecture was designed can be more streamlined and efficient, and thread those single records, if you will, that get pulled together for an individual employee in a way that hopefully really does get to the root cause of some of the syncing issues that we are doing manual workarounds on now, instead of getting to the permanent solution. And so that's where the architecture and database is the key part. And we weren't really in a position to be able to address that before, but with the resources, we're prioritizing that as that has to be done.
Next slide, please. The other two priorities that we have established as far as our strategic priorities is SOL migration to a new platform. So everybody, I'm sure, is aware of the Secure Access Washington and how troublesome that can be. So we're going to transition from the SOL, Service Access Washington, to what they call the digital experience, which is being hosted by WATEC. It is a platform to support emerging technologies and enhance security. This initiative is part of Washington State's investment in improving digital experience for residents, businesses, and state agencies. The DEX program works with agencies to make online services simpler, faster, and more secure, aligning with the Governor Ferguson's Executive Order 25-06 to enhance digital services statewide. Our technical team has been working with SEBB, and we're looking at windows of opportunity to consider the migration period, considering blackout dates. And right now we are still in that development process of identifying that, but I will keep you informed as we go through the session, the board schedule, as to as that situation develops. Okay. And another priority, Dave and Jean have both mentioned at different times, is the 834 file production. By shifting eligibility file generation from Pay 1 to the benefits 24/7, we aim to improve efficiency. The 834 file standardizes the electronic transmission of employee benefits and enrollment and maintenance data from the employers to health plans. Our goal is to complete the migration and integration by 2028, ensuring scalability and compliance. That's the goal, right? Pamela, I see you over there nodding your head. All right. Okay.
And just to put a finer point on that one, the disconnect that is happening sometimes where a school employee or a state employee is going to a provider and they're like, you're not covered. That is a direct embodiment of the disconnect between the enrollment being in benefits 24/7 and the eligibility file and accounting being in Pay 1. And so this migratory effort of making 834s come out of benefits 24/7 would at least ensure complete consistency between the enrollment elections that are made and what the carrier sees. As Jean's, I think, going to talk about in a moment, we still would have migratory work into accounting and billings, and there's still that piece, but at least from the member experience of, it should eliminate by that point the wider issues we've seen of members being told they're not covered, and benefits administrators going, it looks like they're covered, and then we're going, but they aren't covered in Pay 1, and you don't see Pay 1, so you don't know that, and we understand why everyone's confused, but that should slay that dragon eventually. And when we say plan year 28, we mean fall 27's open enrollment, just to be clear.
Next slide, please. The future of Pay 1. Pay 1 will continue to operate for accounting and compliance functions through 2028, including tasks such as letter generation, the Affordable Care Act integration, and CMS agreements. A long-term strategy for a full migration away from Pay 1 will be supported by future decision packages. The impact, these initiatives are designed to enhance operational efficiency and reduce enrollment errors, improve scalability for large employer groups, and lay the foundation for future benefit plan enhancements without disrupting the core system. Our next steps, from a technical perspective, we're going to go, obviously we've already initiated, but we're going to continue the stabilization and API development efforts, initiate and begin planning the SOL to DEX migration, and start preparing for the full transition of eligibility file production to benefits 24/7. Are there any questions to the are there any questions to the information that I just put out? No? Yeah, I know.
Great. Well, Travis, Jean, thank you. I just can't underscore enough just the importance of our underlying plumbing and the systems that we use. So of the work, it's the make or break, the aspects of the things that actually make us be able to do our mission. So thank you. Right. We are doing really well ahead of schedule now at the moment. So Dave, I'm going to turn to you to sort of continue on the conversation that you had related to the fully insured procurement update. And then I'm going to just have you continue on, which you're the next portion of the program, to also give us a preview of the upcoming 2026 session and what topics will be a preview for that.
Perfect. Look at good afternoon. It is afternoon,
Yes.
everyone. So I'm going to try to thread together some of the pieces that have been talked about between Tanya's presentation, Travis and Jean's presentation, and picking up where we left off last board season related to the fully insured procurement discussion. So we'll go to the first slide here. And just as a reminder, we ended the board season with a pretty robust presentation about what it takes to host a procurement. What are the steps of that? What is the timeline? And when we left off, we were talking about, if all of the steps align, the earliest of an implementation could be the fall 27 open enrollment with a portfolio that would be different than it is today come January of 2028. The agency left saying there was, I think, Pam, you were the first one to say, do we need a resolution to this? And I was like, oh, no, we hear your interest and the PEB board's interest loud and clear that there's this pursuit. There are steps in the authority dance that need to happen. The agency will run with that and report back. And so here I am 6 months later talking about what has already happened and where we are. And I left off saying the next preview or next step, that would be kind of an overt public step around the steps towards a medical plan procurement would be a decision package from the agency with identified resources that need to be picked up in order for that to be able to be launched. As you know, we put forward that decision package, and the good news is that it was picked up. It was rebranded to emphasize the IT pieces, and the funding was put in the governor's supplemental budget to proceed with the types of changes that Travis was just going over. Now, that funding request is for 3 fiscal years beginning July 1st, and you might go, well, it's January, and that's not July, and there's a whole lot of things that happen in the next 50 days with the legislature, and the governor's budget is the start of the conversation. It's not the end. But we don't have time to wait. So right now, with kind of some vacancy savings from held staff positions that have generated as part of the hiring freezes and kind of really throttling a lot of the things on either travel or contracts or positions, kind of leaning into all of this work within the current remaining 6 months of this fiscal year. And so we're winding up all of that work, and then we'd have the project funds that would become live July 1st if that's in the final final supplemental budget. If the final budget doesn't include that, then we would have to talk about what parts of our ambitious plan would need to be scaled back based on not having funding. But in the meantime, we're kind of winding up with that variance right now. So just wanted to explain to people, how are we starting to do the work now if the funding request isn't final and doesn't kick in until July? This is how budgets work. And that's my reminder that lunch is over. That every day I remind myself, and I forgot to turn it off. So in case anybody wonders, lunch is over. Let's see. Just a quick reminder from this first slide, like at the end of the day, I've been trying to say it this way. Eventually, there will be a procurement here. It's not a matter of if, it's a matter of when. And when we left off last July, we were talking about some of the major goals that could come from a procurement for medical plans. It's been in the SEBB program, we've done one such procurement. That was for the launch of the program, and it was done in 2018. And in the PEB program, there's a debate as to how long it's been, but it's been at least 20 years. Yes, it's been at least 20 years. And so, it's time to go to market at some point, every couple or every decade. And, an end goal would be having a range of plan options that is more similar tomorrow than it is today between PEB and SEB. We have a lot of households that have eligibles in both programs, or people who change jobs, or whenever you have a non-Medicare retiree, or you have someone who is not yet Medicare aged who retires from K-12 and comes over to PEB, they have to switch from a completely different set of plans than exist from the SEB system. And then when they become Medicare eligible, they switch yet again. And so there's a lot of clunkiness in that for the member experience. If the plan options were more similar, there could be some reduced administrative costs by not having to have so many different certificates of coverage and having to make multiple different charts comparing everything, because there would be a lot more similar in the future. And there are a lot of questions that come from members and legislators and stakeholders that ask, why does something exist in one program that doesn't exist in the other? And the reality is we shouldn't need to distinguish based on who the purchaser is between PEB and SEB. And hopefully we're not distinguishing between the purchaser is for non-PEB and SEB and Medicaid. And we're just kind of trying to address things for the health of the population, regardless of where your insurance differences. But even today, we have differences between the two programs. So one of the goals of this mythical procurement, if you will, is to align the portfolios in a much better way. And then our contracts themselves have contracts that were made. When you go out for procurement, the dynamics of negotiations of contracts are different than in a renewal period. And while we've made some modernization of the PEB contracts over the years as value-based purchasing has, come up in recent decades, especially if the procurement hasn't happened in over 20 years, those are different than the contracts that we were able to launch for the beginning of the SEB program. So we'd be able to align our contracts and kind of the performance metrics in a better way at the end of the day than exists today in the two programs' respective portfolios right now. Also, inherently, a procurement results in more competition and some innovation, and those are all desirable reasons why there is periodic time to go out for procurement. And then I kind of already talked a little bit about the advantageous contracting options. The next slide is just what pulled this from the materials that we ended on July, just to remind people of the high level map of what a procurement takes and how it kind of fits into roughly a 2-year time frame. We are still in this. This is what I'll talk about in a moment, but with where we are in the decision package and the emphasis being on the criticality of IT functions, we are still in the development phase. If we were on a path to implement for 2028, we would be probably very close to, if not almost immediately, issuing an RFP. But the way that the decision package was funded and the way the conversations happened with the governor's office and OFM and the agency, we all really got to that piece where I said the criticality of getting some of this infrastructure modernized to avoid some more terrible circumstances that could happen if you have hundreds of thousands of plan switching and extensive data sync issues. No one wants that to happen. And so it was just decided that there just needs to be this prioritization of IT. So what we're going to be doing is we're going to be working on RFP documentation to be able to, when we are at a certain point in our IT work streams, be confident that we'll be able to hit the goals of completing the 4 subject areas that Travis went over once certain milestones have been reached, and those aren't fully identified yet, but we're in the project planning of that right now. Then we would be coordinating with the governor's office and OFM to say now is the time to release the procurement. So we're going to be working on documentation to be ready for that day, while also, wow, we're just, well, no, that was Dave pushing his snooze button on his alarm instead of his dismiss button. But now we're just turning the phone off, so there shouldn't be any more alarms. I'm gonna have to remember that on Thursdays. I'll have to set a reminder to turn off my reminders. So where was I? So we're working on the milestones that would be agreed upon to then be able to release a procurement. So I do want to be clear, if we go to the last slide in this presentation, that we're going to be continuing preparations for a procurement, because again, it's a matter of when, not if. But given where we are and the IT work that needs to be done, when we left the board season, I said if the stars all align, the earliest would be plan year 28 with fall 27's open enrollment. We're now on a path where the earliest that a procurement could have results that are implemented would be plan year 29 with open enrollment 2028. So just moving forward, imagine all of the work that Travis has described would be done. We would have redesigned different parts of our data base and architecture. That's kind of one train on the track that needs to be done. The second is the APIs, especially with UW and WSU. Those are critical to get done in our system because data doesn't flow the same way for those two organizations as it does for everyone else who's in PEB and SEB. And we can't generate 834 files for the entirety of both populations until that work is done. We hadn't originally anticipated SAW migration, but WATEC put that on our to-do list, so it needs to be on our to-do list, and it will be. And then all of that culminates with being able to move the 834 files. So we started this conversation in the decision package. If you go and read it carefully, you won't see words like database architecture, you won't see SAW migration, and you won't really see API. It all talks about 834 files, but those other 3 bodies of work are all condition precedents to being able to do the 834 file work. So that was all kind of subsumed in our mind, and we provided clarification about that along the way as the decision package was being reviewed by the governor's office. I want to pause to see if there's any questions at the moment, because I know this is a really big and important topic. Allison's reaching for a button.
I'm curious how this coincides with a possible Medicaid procurement and whether you would run two procurements at the same time, if some of those same technical issues exist on the Medicaid side and there's sort of an equal pathway to be getting ready, and just sort of how that affects maybe from more of an agency perspective.
Yeah, I'm happy. Thank you, Allison. Good question. So, I mean, I think one of the values of the HCA is obviously as a purchaser, we have sort of these opportunities to take a look across all of our book of businesses and say, where can we align? I think the intention in the future, well, let me just start with the Medicaid piece. There were a lot of conversations, obviously last legislative session, around Medicaid reprocurement stemming out of some pieces of legislation. The world looks very different a year from now with HR 1 and now what's on the agency's plate to take on. So we are not in any conversation at the moment related to procurement on the Medicaid side for us at this current juncture. However, what we are doing as an agency is saying in the areas that are most important for our Medicaid program of access, quality, provider impact, and member experience, what do we want to achieve in the future in thinking about our delivery system, particularly after post HR 1 implementation, what that looks like. Those elements along those 4 key areas should absolutely align in the thinking that we have across the agency anytime we're sort of out. So I think the spirit and the effort is that we definitely see the value of ensuring that any procurement is sort of coincided together. They also, as Dave knows, procurements tap into our shared resources in terms of contracting staff, in terms of the elements that we need internally. So it would be foolish not to be able to, but just wanted to make sure that was clear on the Medicaid side. Yeah.
I think I'll just add, yeah, the agency can walk and chew gum, but then there's walking and chewing gum while you're juggling knives and spinning plates. And so there's a lot, there are some shared resources that Ryan was referring to that would be tapped, but there are also some separately funded positions. Tanya talked about how there's different funding, different color of money, as we say, that funds various positions in the agency. And so there is not the impossibility of being able to do such procurements at the same time. And that they certainly don't have to happen at the same time, but that doesn't mean the same principle. Oh my gosh, I really did turn off my phone and apparently I pushed restart. Okay, now it really is powered off. That's so embarrassing. I'm like mortified by that has now happened 3 times. Lunch is officially over, folks.
Yeah.
And I know it. Yes, there's no more snack. Yes, to the extent I was gonna have a cookie, I'm cut off.
Yeah.
That's okay. So there's definitely conversations. I mean, I've had conversations with some of the folks who would be over Medicaid procurement just to understand timing and make sure that we have similar ways of thinking about things. And so all that coordination happens. But there's not a sequencing that inherently has to happen for either of them to occur or a complete prohibition on them occurring at the same time. But we're nowhere near any of them happening at the exact moment.
Correct. Yep. Amir, did you have a question?
Yeah, Dave, I had a question because in 2025 legislation, there was also possible legislation of PEB and SEB consolidation. I don't know if that also plays a factor as you're thinking about procurement and the timeline as well, whether if a consolidation does happen along the way. It sounds like you're trying to align the procurement anyway, so the benefits match with each other, but how that plays a factor into the spinning knives and everything else that's happening.
Yes, the spinning knives. Yes. Originally when we were starting to have the conversations about a potential procurement, and the board was beginning to have more of those conversations in the public board meetings last year, there was that simultaneous legislation that was being considered, and it was having hearings. And there is a sequencing, like, do you have a procurement before a consolidation if that were to happen, or vice versa? And I think at the time we were just kind of along for the ride as to, well, if a consolidation happens, obviously a procurement, it's easier to have uniform results where there's only one board acting than you have 2 boards acting. So we'll just kind of see how that plays out. But we can't wait to have a procurement until consolidation happens, because a consolidation is not a foregone conclusion. In fact, it took 30, 35 years for the SEB program to be decided to exist, and decades of debate before having a consolidated K-12 program that we sit here today in. So we were curious about, it would have been the sequencing would have been just different, but we can't wait to see if that is actually going to happen. And so far there aren't any discussions or hearings or resurrection of that bill that Kate brought up. So, we can't wait for that. That's why we're working on the IT pieces and then the procurement pieces. And we will put in the procurement documents that, a successor program that combines the programs, has the authority to continue to use these benefits and all of that. We actually tried to do that in the original procurement in 2018 for the plans that SEB has today, is that they could be leveraged at some point by the PEB program. So we'll do foresight around that. And if something changes while we're in the middle of all this, we'll just respond to it. But we're not going to wait to see if that happens anymore. But we were curious how last session would play out with that bill and if it would inform things. But right now it doesn't seem like there's a lot of momentum or activity there. But that doesn't mean that it can't be picked up. And who knows, maybe in 5 years or 30 years, it'll be one program, hopefully not 30. From my opinion, it's very long management to manage 2 programs that differently. But we'll just kind of respond if and when that happens at this point.
Pam?
Excuse me. I appreciate your explanation of where we are in the process, because it really sounds like we need to get like the infrastructure settled and all of us on the same system. I can't remember what half of them are called, but why do something 2, 3, 4 times if you can just do it right one time? So I appreciate that update.
Thanks, Pam. And I know it's probably frustrating to hear, like, results of a procurement might not be until 2029 at the earliest now. But it's really about, and this is a important reminder that I wanted to try to set the stage for, is like, the royal we, the agency, the boards, the legislature, everyone will have to be really restrained in trying to limit large changes like introducing new plans, because all that does is divert our IT resources to making changes in the system that we're trying to get away from, rather than investing in the future of these systems. And so trying to stay steady and things that could divert from IT resources, if there are ideas that come up along the way, Travis, Jean, and I will be highlighting, like, that's the type of change that's going to risk the timeline for all of the work that was described today and is funded by this. Oh my gosh, Jean, can you take my phone away?
We have an IT department.
Dave needs an IT consult on his phone.
Just keep powering off. Power off.
Where did Travis go?
I'm like, I don't understand. Wow. We'll be the first to say, that could risk the projects that we're working on. And so keep our eyes on the prize that we can get this done so that we can move to these broader policy goals for these programs. Laura.
How does that play into, so there's the rate setting process, and we still vote, or, the board still has the authority to authorize plans being offered. So do we still have that ability? I mean, obviously we still have that ability to not authorize a plan if the rates come in high. Is that still the case? We can still choose to.
Yeah, thanks for asking for clarification on this piece, because introducing a new plan takes significant more IT resources. The way I think of it is you have to build another lane on the highway, and that's a lot more work than it is to close a lane on the highway. So retractions always do take some IT resources, but not of the magnitude of building and expanding the highway. Maybe that's that's the best analogy I have there. So there are still ways to kind of respond to current dynamics and kind of narrow options, but the expansion of options is really the part that would risk all of the timelines that we've been talking about.
Other questions? Okay.
Now we talk about 2026. So at the end of every board meeting, I try to preview what's coming up next, but I just want to remind people of the cadence of the year and the things that'll be happening. So our next meeting is on March 5th. That's about a week before legislative session is over. And so Kate will be back talking through the bills, and we'll be talking about what will need to be implemented, and some of those bills, like if 2160, which looks at the prior year or prior 2 years of eligibility in the SEB program has changes, then you're going to start to see us teeing up policy resolutions to implement those bills. Tanya will describe what happened with the budget, or I guess in March, what is happening with the budget. But, we'll go through the story arc of where we are on the budget and what was actually funded and where we're implementing things. We want to give you some updates on how the new collective bargaining agreement flexible spending account distribution that is started this month for school employees is going. FSA, that flexible spending arrangement, isn't a benefit that the board has authority over, but we still like to describe to you the big picture of what's happening. And so, we're deep into the implementation of that. Members start getting their debit cards if they didn't sign up for it within the next 2 weeks. And so that's flowing. So we want to give you some updates about how the launch of that is going in the program. We do know that in our policy and rules area, in addition to anything that happens because of bills, we have yet again some dual enrollment refinements that need to happen on the dual enrollment prohibition and the resolutions that you've had many actions on in the past recent years. There's a few more things to work on in that area. We'll talk through kind of Smart Health, where we are on utilization, and then begin talking a little bit about the wind down of Smart Health that is forthcoming for 2028. We're going to try to do every meeting, almost every meeting. We'll see exactly how it plays out. Some updates from Gene and Travis on where we are with the project plans, because I want to be able to ultimately describe some of the milestones we hope to achieve before that would be kind of condition precedents to moving forward with the procurement. And then, of course, we will have the rate setting season and votes. That happens more in the spring. So just remember that we have ledge and budget updates kind of into the March, April area. Policy making tends to be March through May, and then rate setting tends to be May through July. So that's kind of the cadence that we're on and what it looks like for the board for this year. And I'm just waiting for my phone to go off again.
Any questions from the board for the season? Okay, great. I think now we've reached part of the meeting where we will take general public comment. I'd like to first gather a list of speakers that have been signed up for public comment. And if you're virtual as part of that, I just want to advise you to click on the virtual hand wave if you would like to speak, so that we can gather a list of speaker. And if there's also anyone in the room that would like to speak as well. Is there anyone in the room here who would like to speak? Okay. And are there any virtual folks who would like to speak? Any hands raised, Tina? Okay. Once, twice, three. We all good? Okay. Wonderful. So with that, I just want to note, as Dave had mentioned, that the next meeting is on March the 5th. So that'll be a week out before session is concluded. We'll be back here at 9 a.m. We'll use the same format with Teams and also attendance in person. Any other comments, Dave, before we adjourn?
Nope, just thank you everybody for the day. Apologies for my phone interruptions 4 times, and that'll be fixed next time.
Anything else from the board? Meeting adjourned. Yeah.
A shared friend of ours, Sandy.
Oh.
So she started.